Ma'am, we are in live.
Okay. A very good evening to one and all of you here. A truly a warm welcome for our IEDU webinar. And this has been a series of webinars which we've been conducting once a month. And it has been very well received and it's a storehouse of information. And it happens each time because of great speakers like all of you here. So let's look forward to a very interesting 2-hour session with such top-notch speakers amidst us. So I take this opportunity to very warmly invite Dr. Arif Khan, who's a speaker and is also on our expert panel. He's a professor of ophthalmology at the Eye Institute at Cleveland Clinic, Abu Dhabi, and has taken great inroads not only into pediatric eye care services, but is going to be talking on something very interesting and something many of us may not be knowing in such great detail, and that is what ophthalmologists need to know about genetics. We are very lucky to have with amidst us my very dear friend, Dr. Meenakshi, who is a Chief Medical Officer, Pediatric Ophthalmology and Adult Strabismus Services from the Arvind Eye Care Services, Tirunelveli. A warm welcome, Dr. Meenakshi. We have with us my young friend, Dr. Virendra Sachdeva, who heads the GMR Varalakshmi campus at Visakhapatnam as the consultant ophthalmologist at the Children's Eye Care Services. And we have with us Dr. Veena, who was to join us, but may be unable to because she has some guests at home. But all the same, it was nice to have had her thinking that she'll be with us, and we may be lucky to have her. She's the chief of the pediatric services at Arvind Eye Care Services at Pondicherry. With us is Dr. Jaspreet Sukija, who have been very lucky to have with him even during my ARC term. And he's a senior consultant pediatric strabismus and neuro-ophthalmology at PGI Chandigarh. We are also really indebted to have Dr. Kumar Manikubel with us, who works in medical genomics, epidemiology, and in genetic counseling, and is also a research director at the Narayan Nethralaya Hospital, Bangalore. And I think he would be just the right person to take the discussion forward with Dr. Arif. I'm very lucky to have with me Dr. Murlidhar, who's just not the right hand alone, probably Murli, the right side of my brain too. And he is the our senior consultant pediatric ophthalmology, strabismus, cataract, glaucoma, and neuro-ophthalmology at the Eye Foundation group of hospitals based at Coimbatore. So without wasting time, we shall go on to our first speaker, Dr. Arif Khan, who is going to be talking to us on the next 25 minutes on why do pediatric ophthalmologists need to know genetics. So on to you, Dr. Arif.
Thank you so much. Can you see my screen and hear what I'm
saying? You could be a little louder.
Okay, let me get closer. Can you see my screen and hear what I'm saying?
Yeah.
Yes.
Okay, well, thank you. What a pleasure it is to be part of this webinar. I wasn't aware of this series, but I'm certainly going to look back at the previous ones and hopefully in the future catch what the interesting topics you have. Thank you for including me. It's great to see some old friends and make some new ones here I see among the panelists and speakers in this webinar. So what I'd like to speak to today is a topic that I enjoy speaking about, and I hope you'll enjoy listening also. It's why do ophthalmologists need to know about genetics, case examples, and patient impact. And let's just get right into it, some case examples. Case 1 is entitled A Decision for Abortion. This is a 3-year-old male who was referred to me for evaluation of cone rod dystrophy. His background story is that he was noted to have nystagmus when he was 1 month of age. At that time, he had an ERG done, and he was diagnosed as idiopathic recessive cone rod dystrophy, even though a genetic panel was negative. And the parents were told that the child is going to have poor vision, which will decrease to blindness. This was based on the nystagmus and the ERG that was done. Soon after that, the mother became pregnant again, and she was told that the unborn baby is likely to have a 25% risk of having the same disease. So because of this, the family decided that they would go for an abortion, and they had an abortion based on being told that the unborn child has a 25% risk of having a disease that is going to progress to blindness, which is the diagnosis that was given to the proband, the first child that was born, based on nystagmus and the ERG. Now, a few years later now, we flash forward to a few years later, and the parents noticed that the child, the first child, seems to have good vision despite having nystagmus. So they came to me for another opinion, and this is where the story begins with me. So that's the background of this case. Now, there's some issues with this case. What are the issues with this case? One, doing an ERG in a 3-month-old, and two, making a diagnosis of a recessive disease without genetic confirmation. These are two problems with this case. ERGs in infants are subnormal, and you have to be careful about doing ERGs in infants because it can be difficult to interpret the results. This is a normal 5-month-old male child, and the ERG tracings are below normal, but actually they're normal for the child. So infants have subnormal waveforms. So the first mistake in this case is they did an ERG on an infant, it was subnormal, and they felt that that was indicative of a retinal dystrophy. The second problem with this case was that it was assumed that the child had recessive disease. Now, it's true that many retinal conditions, pediatric retinal conditions, are autosomal recessive, particularly in Asia and the Middle East, where there's a higher incidence of consanguineous marriage. But still, you should not diagnose a recessive disease unless you have a genetic confirmation, because although recessive disease is common, there are other things that occur as well. And just because there's a high likelihood for recessive disease, it doesn't protect you from getting a disease that's not recessive, that's dominant or X-linked. So going back to this child, I gave you the background, and they've come again because they feel the vision is better than predicted, and they didn't feel the vision went down in this first child. So they've come for a second opinion. And when we examine the child, he has subnormal vision. He has nystagmus, but it's not terrible vision. And he has a refractive error, no strabismus, and nystagmus. And the retina appearance is abnormal, which is what led to that diagnosis of idiopathic recessive cone rod dystrophy. And here's the image, the retinal image of the child. And there's a normal image shown in the lower corner just for comparison. And certainly there's abnormality there. We're seeing too much of the choroid. This could be from chorioretinal atrophy, but it also could be just from lack of pigment. And actually, this looks to me like albinism. It looks to me like ocular albinism, the X-linked form of albinism. The people can have albinism just in the eye without having the skin affected. That's X-linked albinism. Further evidence of this, when we look at the patient and do an OCT, there's no fovea, which is more support for a diagnosis of X-linked albinism, which is a stable disease. Now, how can we prove this? Well, of course, there's genetic testing, but that takes time. But there's also often something we can do with the help of someone who's in the room often. And this is the mother. And when we look at the mother of this patient, you can see that her retinal has this mud-splattered appearance, which is more obvious on the autofluorescence. This is the classic carrier sign for X-linked albinism. So we just made a genetic diagnosis of X-linked albinism in the child without doing any genetic testing. This is something very powerful, and you have to be aware of this condition to be able to diagnose it. If you're not thinking of it, you're never going to diagnose this. X-linked ocular albinism is a very underdiagnosed condition in children who come in with subnormal vision and nystagmus. We did genetic testing to confirm, and of course, the child has mutation in the gene, and the mother is confirmed to be a carrier. X-linked disease in ophthalmology is fascinating, really, because we often can see carrier signs in the females, although they're asymptomatic. Here's a classic pedigree for X-linked disease. Of course, males are affected. Females are asymptomatic carriers classically, and there's no male-to-male transmission. X-linked disease is underdiagnosed in ophthalmology because people don't think of it. And it's something we should always consider when we have a boy who comes in with a condition that could be X-linked. Ocular albinism is in particular an X-linked disease that's underdiagnosed. There's a lot of variable expressivity. The important point is relatively stable, and some of these patients have pretty good vision. They can be 20/50, 20/40 vision even. The thing that's confusing to people is the nystagmus. And here's a point I would like to make. These children have foveal hypoplasia, of course, and they can have subnormal vision from foveal hypoplasia. And if it's bad enough, they can have nystagmus from subnormal vision. But many patients with ocular albinism have subnormal vision, not from have nystagmus, not from subnormal vision or foveal hypoplasia, but actually from the miswiring that occurs in nystagmus, in albinism. So the nystagmus is not a sign of decreased vision in albinism. It's often a sign of miswiring. It's not necessarily a sign of poor visual acuity. And this was a mistake that was made in this case. Seeing nystagmus, seeing an abnormal fundus, jumping to the diagnosis of retinal dystrophy, the nystagmus can be just from miswiring in albinism. What do I mean? I mean this. Normally, we have about 50% of the optic nerve fibers cross to the contralateral hemisphere. So each hemisphere has representation from the ipsilateral and contralateral eye. And that allows us binocular vision. It allows us motor control, avoids nystagmus. In albinism, what happens is we have abnormal desiccation. About 90% of the fibers decussate to the expense of the ipsilateral eye. So it's this miswiring that occurs in albinism that leads to nystagmus. It's not necessarily a sign of poor visual acuity. That's the first case I'd like to share with you. Here's another one. Blurry vision in an inpatient awaiting a kidney transplant. So here is an inpatient consult for blurry vision. A patient is a male in his 20s awaiting renal transplant from the mother. Ophthalmology is called because the patient is complaining of blurry vision. Of course, you know, what is this? Another consult for just a patient who needs glasses? That's what it sounds like. But in fact, this patient actually does have an abnormality. He has this multifocality to the lens here. Can you see that? He's actually got an anterior lenticonus. And this is why he has blurry vision. It's bilateral, just the right eye is shown. So what's the issue with this case? This is a patient who has anterior lenticonus. He's a male. He has renal failure. It's likely Alport syndrome. This is often X-linked, and the planned renal transplant is from the mother. So this is maybe the only time in the history of renal transplantation that an ophthalmologist stopped a planned renal transplantation, because this patient had undiagnosed Alport syndrome, was awaiting a transplant from the mother, but this is an X-linked condition, and had the mother given the transplant, it would have failed. Again, look at the power of X-linked disease and of ophthalmology. Here again, you can see the lens is bulging anteriorly. This is anterior lenticonus. In Alport syndrome, sometimes you see some retinal flex as well. Alport syndrome is another one of these X-linked diseases where we should be aware. Alport syndrome has different types of inheritance, but X-linked is the most common. And anterior lenticonus and idiopathic renal failure, think of this condition. These patients are not diagnosed if the condition is not thought of. Here's a third case of a lazy boy. He's a 10-year-old lazy boy who refuses to go to gym class because he gets too hot and tired. Specifically, he complains of a burning sensation on his hands and his feet. He recently developed a rash under his belly button that was attributed to poor hygiene. There's no clear diagnosis. He just they thought he was lazy. He came for an eye exam accompanied by his mother. His eye exam is within normal limits. Now, what's the issue with this case? When you have multiple findings that are vague and there's no clear diagnosis, sometimes it's from an undiagnosed single cause, which may be treatable. And to be honest, when this child comes in with these kind of complaints, I really don't know what he has. But I know that there could be something that's being missed. And something that I've gotten to a habit of doing is when I have a patient who's referred to me, and I think it could be a genetic disease, and I'm not sure what's happening, I always look at the parents that are in the room. And when we look at the mother of this patient, she has this vortex keratopathy. Vortex keratopathy can be from different things, but in this particular patient, the mother and the child had Fabry disease. Now, the mother, it's X-linked, so she's mildly affected, but her having this vortex keratopathy puts all of these findings that this lazy boy is having into proper context, and it all makes sense. Again, the power of carrier signs in ophthalmology, how ophthalmologists can be helpful, so helpful in making these diagnoses. This boy had undiagnosed Fabry disease. This is not just an academic diagnosis. There is treatment for Fabry disease. And it was of examining the mother that allowed us to make this diagnosis. Again, if you don't think about it, these things are never diagnosed. I think I've shown you how interesting I think X-linked disease is. I could talk about X-linked disease for this whole lecture that I'm giving, but I want to move on to a couple of other examples of how genetics is important in pediatric ophthalmology and why pediatric ophthalmologists need to know about genetics. This is case 4, congenital maculopathy, told nothing can be done. So it's a 4-year-old girl with developmental delay and maculopathy. She was diagnosed with a congenital retinal problem when she was about 1.5 years old and bumping into things. She's developmentally delayed. It was assumed that all of her issues were related to a perinatal infection, and she's the only child. Her vision is down. She has nystagmus. She has refractive error, and she has this maculopathy. You can see it there. That's the right eye. The left eye is similar. It's just an atrophic central macula. The left eye is similar. So what are the issues with this case? Well, you know, it was assumed that this was from a perinatal infection, and certainly perinatal infection can cause a maculopathy like that with developmental delay. But there's also the issue that this could be from gene mutation rather than infection. And this has implications for future children and even for possibly for treatment for the child if it's a neurometabolic disorder that's responsible for the developmental delay. So I would like to do an ERG in this patient to understand the retina better, but because of the developmental delay, we didn't. Instead, we went right on to genetic analysis because of the possibility that this could be a genetic etiology. And indeed, we found a mutation in a gene that explains the patient's maculopathy. So the maculopathy is genetic. It's not from infection. But interestingly, we also found that this girl had a separate mutation in a separate gene that was responsible for her developmental delay. So she had 2 different problems here. She had the retinal problem and she had developmental delay from 2 different gene mutations. It was all assumed to be from a single etiology before perinatal infection, but it was actually 2 different diseases. No way to know this if we didn't do genetic testing. No way to know this if we didn't suspect the possibility. What can we do for this family? Unfortunately, there's no treatment for either of these 2 things other than symptomatic treatment. However, the parents wanted healthy children. Now we know what's going on, actually, and this family underwent pre-implantation genetic diagnosis with knowledge of the disease genes in the first child that they have. And now they have healthy triplets because they've selected the embryos and they've effectively eliminated the disease from future generations of the family. So that's the power of genetics. This family was previously told nothing could be done. Certainly something could be done. Here's a 6-year-old female with high myopia and phacodenesis. Here she is. She has high myopia and she has phacodenesis. Actually, this wasn't diagnosed before. It's important whenever we have a child who comes in with high myopia to use a slit lamp and look at the lens, because sometimes we have, although most myopia is axial, sometimes we have problems with the lens that's leading to high myopia. Now, I think we all know that patients with high myopia and phacodenesis or ectopia lentis are at risk of having Marfan syndrome or fibrillin mutation, and that's something that should be considered in any child who has ectopia lentis. And before this child ever came to me, the patient had genetic testing for fibrillin mutation, and it was negative. So they were told, nothing to be done, just give the glasses and consider lens surgery if the lens dislocation it becomes unrefractable. So what's the issue with this case? The issue with this case is negative genetic testing does not rule out disease. Sure, a patient like this doing fibrillin testing to look for Marfan syndrome is reasonable. But to be frank, I wouldn't even do that in a patient who came to me like this. If I'm suspecting that the patient has fibrillin mutation, I would screen for Marfan syndrome, because whether or not the gene mutation comes back positive, it doesn't eliminate the risk. If it comes back positive, great. But if it comes back negative and you have a high clinical suspicion, it could be just that the method of genetic testing didn't pick up the mutation. So I insisted that this patient have an echocardiogram, and sure enough, the patient has dilatation of the aortic root. It's been progressive over time, and now the patient is managed by pediatric cardiology. Doing genetic testing and not finding a gene mutation does not mean the patient does not have the genetic diagnosis that is being suspected. And this is particularly important in conditions such as Marfan syndrome, where it can be life-altering to make the correct diagnosis, because progressive dilatation of the aortic root leads to sudden death in these patients, and it can be managed quite well if it's picked up early. That's a little bit of a burden of us as ophthalmologists who see patients with ectopia lentis. We are in the position to pick up these patients and suspect them better than anyone else. Of course, someone with obvious Marfan syndrome, anyone would recognize them, even a layperson would recognize them. But some of these children who come with an ectopia lentis, they don't look like they have Marfan syndrome, but they're going to become Marfan syndrome. And we have to rule it out or refer to someone who can manage the suspicion appropriately. I think I'll finish up with one last case, and it's not this one, actually. It is this one here. My slides got mixed up a little bit. A patient who came with a syndromic retinal dystrophy and was told that nothing can be done. He's a 20-year-old male with poor vision and generalized delay since early childhood, and he's got this dystrophic retina. Certainly, for most retinal dystrophies, we don't have a treatment, but there are exceptions. And everyone in this day and age, really, I know it's not always financially feasible, but I don't feel comfortable unless we have a genetic diagnosis, especially if there are other signs or symptoms, because sometimes the retinal dystrophy is the sign of a metabolic condition that's treatable. And in this particular patient, he's relatively small and thin, he's intellectually delayed, he avoids meat because of unpleasant diarrhea. I'll just get right to it. We investigated him and we found out that he has A-beta lipoproteinemia. This is an abnormality of absorption in the gut, and this is why he has retinal dystrophy. He's coming to me at 20 years old, and we're making this diagnosis now, but this retinal dystrophy started in infancy, and it's related to this abnormality in absorption of fat-soluble vitamins. A-beta lipoproteinemia, also known as Bassan-Corwin disease, is considered a very rare condition, but it's actually more common than you think because it's not being picked up. These patients have fatty diarrhea, they have retinal degeneration and neurological changes. What's so tragic about this case and cases like this that don't get diagnosed until adulthood, patients who are diagnosed in childhood or infancy who receive vitamin A therapy prior to 2 years of old do not develop neurological disease and systemic complications that are associated with untreated disease. So really, we have to look at these children who come in retinal dystrophy, and every child who comes in retinal dystrophy is for me, is a metabolic disease suspect, syndromic suspect, unless I can prove otherwise. I think with that, I will end, so I stay within my time. I have shared with you some instances of cases that come to pediatric ophthalmology. They came to me, and I've shown you how knowing genetics and understanding genetics significantly optimizes their care and really is the only way to give them the highest standard of care. I don't think everyone needs to know to order genetic testing or make the specific diagnosis, but I think everyone should suspect when we're dealing with such a condition and be able to refer appropriately to someone who can handle it. So thank you very much.
Dr. Arif, that was an amazing talk. Like, I felt that you had hardly talked for 8-10 minutes, and I wanted to tell you that you have 25 minutes to talk. So that's how gripping your talk was, with so much information. And I promise you, we'll come back to you and ask you to give a talk for an hour in one of our future webinars. It was a big eye-opener for us. So is Dr. Kumar Manikvel? Yes, doctor, you are there with us.
Yes,
I would be very happy if you could steer some discussion and make it even more useful for us in the next few minutes.
Yes, please. Thank you for asking me to be in the expert panel. And that was a very captivating talk, Dr. Khan. I really enjoyed it, and you presented it in a very practical sense from a clinic point of view. I have some questions. I'll start with the questions, and then I'll move over to the the attendees. The first question I have is about the child with the suspected Marfan syndrome. Was any connective tissue disorder panel done? Because there are 92 genes causing various type of connective tissue disorders like Ehlers, Danlos, and so on. So I just wanted to know, besides Marfan, fibrillin, did you test for any other gene, or was that the only one?
Yeah, thank you. So the patient had been investigated before they ever came to me. The patient had whole exome sequencing with attention to fibrillin and CBS for homocystinuria, and it was negative. They were not looked at specifically for connective tissue disorders, but my suspicion for Marfan was so high, for fibrillin mutation was so high, because I didn't go into the details because of time, because of the ectopia lentis, the phacodenesis, and the flat corneas, because these patients with Marfan syndrome have flat cornea. If they have a flat cornea, my suspicion goes way up. And I told them that it doesn't matter what the genetic testing shows. We have to do the echocardiogram. Now, patients with these connective tissue disorders, they don't typically get ectopia lentis like this. They don't get phacodenesis like this. So it was just the phenotype was the ocular phenotype was so specific for fibrillin that even though the testing they did before, they didn't uncover the mutation. There's some mutation there in fibrillin.
Okay, fine. So now I throw open the questions or comments to the audience, and you can start with questions, whoever has one.
Yeah. Can I ask a question?
Yes, please.
In your patient, Dr. Arif, I mean, no doubt, I mean, it's a pleasure listening to your talk. I mean, you always gain something. And I want to know that we have few patients with ectopia lentis, and we get a pediatric consultation done, and they say nothing marfanoid in these. But when you get the genetic testing done, the FBN1 comes out to be positive. So how do you deal with these patients?
Very, very good point, and I'm glad you brought it up. I really don't care if the patient has Marfan syndrome or not. Marfan syndrome is a clinical diagnosis based on clinical criteria, most recently revised Ghent criteria. They have this, and you check it all off, and that's how you diagnose Marfan syndrome. What I care about is if the patient has a fibrillinopathy, because you can have a fibrillinopathy without meeting the criteria for Marfan syndrome. Because you can have ectopia lentis and you can have progressive aortic dilatation without meeting the criteria for Marfan syndrome, technically. So it's not the appearance of the child, you know. Every child who comes in with ectopia lentis to me is, and it fits the criteria it has the ocular phenotype, is Marfan syndrome suspect, even if the genetic testing is negative, unless it's proven to be something else. So the bottom line of what I'm trying to say is you can have a risk for progressive aortic dilatation and sudden death from fibrillin mutation without meeting the criteria for Marfan syndrome. So if I feel very, very strongly that the patient has an ocular phenotype that suggests fibrillin mutation, even if the systemic body habitus is not consistent with that, I will insist that they continue with the cardiac screening, regardless of the mutation analysis. Now, if the mutation analysis comes back positive, that's fine. That is more evidence for my point. But if it comes negative, it doesn't disprove the point. So I would say this is the power of ophthalmic phenotyping and suspecting that risk for the progressive aortic dilatation.
Okay. So any other question?
Yeah, this is Dr. Meenakshi from Aravind, Tirunelveli.
Yeah.
Sir, the first case you discussed, they had done the ERG at 3 months of age. So it showed the wave pattern is still not very great. So what is the ideal age you would suggest?
Good question. I don't like to do ERG in less than 1 year old. Rarely we've done it, but I don't like to do it because it's difficult to interpret the results. The times I've done it, you know, I showed you a normal one. I showed you a normal one of a 5-month-old, and that was a child that we did because there was a question of whether or not he had delayed visual maturation or not. And we were just looking if it was recordable or not. I wasn't looking to quantitate. And the mother was very concerned, you know, and there was a lot of, you know, family pressure. So we did it just to show that there was a recordable waveform, not so much to interpret it. At least in my setting, I don't feel that I have enough normative data to interpret these waveforms in very young infants to make specific diagnoses, just gross assessments of whether it's recordable or not. You know, we've had patients with achromatopsia. We might just see that there's a recordable rod and there's no cone at all. But we're not looking at the numbers. We're just seeing the presence or absence. So I try to avoid ERGs in infants, but there is a role sometimes, depending on a question you're trying to answer and the situation.
Thank you, sir. Thank you. We had a case which turned out to be CSNB. Initially, he put us like congenital dysdiagnosis, and even albinism sometimes gets recorded as.
Well, ocular albinism,
Yes.
I mean, that first case was ocular albinism. And
Yeah.
I mean, this was a tragedy, this family. I mean, I couldn't believe that somebody diagnosed them with recessive disease and told them, by the way, this happened, it happened actually in India. I'm not going to say where.
Oh.
Somebody diagnosed them with recessive retinal dystrophy and told them that the unborn child has a 25% risk of this blinding disease. And, you know, you have to be careful of what you tell patients because they use that information to have an abortion. And I mean, the parents are very distraught about this, but It was a very, very first time I've ever been in a situation like that. I mean, it's unbelievable. So you have to be careful what we tell parents. Sometimes, you know, I would say that people always feel like they need to give a diagnosis, but sometimes it's quite okay to say you don't know what the diagnosis is. And that's what should have been said to that family. I think there's a lot of pressure to give a diagnosis, to define things, but we have to become comfortable with the unknown. And I'm very honest with my patients. If I feel like I don't know exactly what something is, I tell them. And sometimes you have to wait. You have to be patient, especially in pediatric ophthalmology. Things evolve, phenotypes change. You get more information as time goes on. So
I had one interesting patient, just one last comment. So it's a 3-month-old child with nystagmus. And when we examine him, we have a patch of hypopigmented iris. When we examine the fundus, it's suspicious of albinism. But the importance of genetic testing, as you've stressed, is that when we get the genetic testing done, it comes out to be senior Loken syndrome, and the child has an LCA. So that's how probably this is so important, I mean, getting a molecular diagnosis in these cases.
Yes, that's very important. I think we are running out of time for the next. If anybody has a burning question, you ask. Otherwise, I will summarize this session and we can.
I have a question to ask. Like, most of us have very limited knowledge of genetics, so we come across these terms like clinical exome sequencing and whole exome sequencing. So, what do these actually pertain to? And I mean, are they some kind of a blanket this thing? Or?
Well, that's I don't know how much time we have here to discuss, but I'll just say that if you're not doing this kind of thing regularly, you should really ask somebody else to do the testing, because it's not the testing now is not so much of a problem. It's more the interpretation. I've had so many patients come in diagnosed with diseases that they didn't have because the clinical exome predicted that this is a mutation when it really wasn't. And then on the other hand, you have patients with a disease and it doesn't show the mutation, like the patient with the fibrillin I showed. So I would say that nobody should be expected to be doing this kind of interpretation and ordering the proper test unless they have some experience in this. And it's not an embarrassing thing. You should work with a genetic counselor or geneticist. It's a whole subspecialty in of itself. So
just answering your question, Murali, is that there are about 15,000 single gene disorders or Mendelian disorders known, and all these genes with various kinds of variants or gene mutations are present in a chip. Okay. So when you put all these 15,000 in one chip, then you call that as whole exome sequencing. Okay. So about 7,000 of them are much more common in around the world. So therefore, only 7,000 are there in the clinical exome. At some point in history, clinical exome was cheaper than whole exome testing. Okay. But today, that difference is reducing. So most of us do whole exome because that is safer. Because if you miss some syndrome or you miss some clinical feature that has not emerged in a young child, it's better to do whole exome today. That's the safest way of playing it. With that, I will try to summarize today's talk given by Dr. Khan. He's shown that how important it is for pediatric ophthalmologists to be abreast with genetic knowledge, particularly in ophthalmic genetics, that is fast catching up. It's also important that the therapies are coming, and therefore you should start to maintain a database, and the therapy will definitely be useful for your patient since they are of pediatric age in future, maybe 10 years or 20 years from today, there will be definitely various types of therapies that are going to come. Okay. There are many instances where one of the most misdiagnosed condition in ophthalmology and from genetics point of view is actually inherited retinal dystrophies. And therefore, backing your diagnosis with genetic screening will be the most ideal way to do justice for your patients. For example, macular degenerations have been dealt with, and when you screen the gene, the patient's gene, they found out it was Batten disease. Okay, a gene called CLN3 was mutated. And some of these conditions like Cohen-Alstrom, as it was mentioned, Rett disease, there are some kind of treatments that are available, but not a curative way, but then at least in manageable way. So therefore, it is definitely mandatory today. In fact, Dr. Khan even mentioned about pre-implantation genetic diagnosis, where you can screen the embryos and find out which ones have the mutation, which ones don't have, and the which ones don't have, you can actually implant. And these things, don't think that it's done in some Western world and not in India. It's all done in every major city in India, pre-implantation genetic diagnosis, because we have wonderful IVF centers. And therefore, screening the embryos is not a big deal today. And then you can definitely help your patients, particularly when they're going for their second child. Okay. With that, I'd like to conclude by saying that it was a wonderful talk, Dr. Khan, and certainly you impressed the pediatric ophthalmologist today with very classical examples, how things people learn today step by step and realize the importance of doing a genetic test. And I thank Dr. Ramurthy and also Dr. Murali for giving me this opportunity. With that, we conclude the session, and I give it back to Dr. Ramurthy.
Thank you so much, Dr. Kumar Anikel, for steering the discussion so aptly and so well within time. In fact, Dr. Arif, you were exactly on dot. I mean, I'm truly impressed that the people with your stature and with your information, you still believe so much in keeping up with time. And thanks to both of you for giving us a great kickstart to this nice webinar, and look forward to having you more often in our webinars. Thank you so much.
Thank you.
Dr. Arif, I would also wish you to stay on if you can as an expert panel. And so would I want Dr. Kumar Manikwel to stay. And we go on to our next speaker, Dr. Arun Samprati, who's a consultant at his Samprati Eye Hospital and Squint Center, who's a very renowned pediatric ophthalmologist and squint specialist. And I think he's just the right person to discuss on what's new and important in pediatric ophthalmology. So on to you, Dr. Arun.
Thank you, madam. Am I audible?
Yes, yes.
The slides are visible, madam?
Yes.
Yeah. Thank you very much, madam, for this opportunity. So today I'll be discussing about what's new in pediatric ophthalmology and specifically about amblyopia, as Dr. Muralidhar has told me.
So make it full screen, sir.
It's I've made it full screen. It's not.
No, it's not full screen.
Oh. I'll just stop share again. Share it again.
Yeah.
Yeah. I'm sorry, I'm not able to full screen. Is it full screen now, madam?
No, sir.
Yeah. It's not full screen.
I'm not, actually, to me, it's visible as a full screen. I don't know, it's a sharing issue.
Can you move to the next slide so that we know if you're able to?
Is it visible?
Sir, stop sharing and again go to for desktop.
Sir, I'm not getting that option of desktop, sir.
Desktop, sir.
I'm getting the option of sharing the PowerPoint.
Could it be Dr. Arun? Could I ask Vel Murugan to call you now and help you?
Okay, madam.
So that you
Sure,
know,
ma'am, sure,
in
ma'am,
the
I'll help
interim, we go on to the next speaker.
Yes,
Yeah.
madam. Yes,
So,
madam. Sure.
while Dr. Arun gets his presentation ready, I would request Dr. Lakshmi to open up her presentation. And Dr. Lakshmi is a consultant pediatric ophthalmologist at Abate Eye Hospital, Kozhikode, Kerala. And she is going to take us on to what's new and important in strabismus. So, on to you, Dr. Lakshmi.
Thank you, madam. Is my screen visible or?
It's visible. Again, you need to
Again,
go to full screen. Yeah.
full screen, fine.
Yeah, that's it.
Yeah, I hope now
Yeah,
it's visible.
right. It's fine.
Yeah, I hope I'm audible. So, yeah. So
Yeah,
thank
you
you.
could
yeah.
be a little louder. That's all.
Okay, fine. Yeah. So, at the outset, thank you, Chitra madam and Murli sir, for giving me this opportunity to be with a very august audience and an expert panel from India and abroad. So, when I was given the topic, I was just jaw slackened for some time because what's new and important in strabismus might be a view of perspective. So I take this opportunity to discuss few of the publications done in the recent years in the field of strabismus. And before that, I would like to start off with the scenario in India, where with the initiative of Pradeep Sharma sir, actually, the squint surgery has turned out from being a cosmetic procedure to a function restoring surgery. And there has been certain directives in insurance claims for changing them. So that has been a boon for patients to restore their function. So we come on to the next topic of usage of botulinum toxin in strabismus surgery. I think my screen is stuck. Just 1 second. Yeah. So the usage of botulinum toxin, we have Cochrane reviews, which was first published in 2009 and has been updated till 2023, which includes 4 randomized control trials, and still there are ongoing trials. But however, there has been low certainty of evidence to comment that botulinum toxin is superior to surgical management. But however, it is definitely promising in various situations like, it's acute comitant esotropia, strabismus, and strabismus with binocular potential, but variable angle, and in paralytic strabismus, as publications show. So the next thing in strabismus is a shift from the usual resection to plication. Most of us have shifted to doing plication on a regular basis. So there are meta-analysis and systematic reviews on this, and which has shown a promising result of plication compared to resection, because plication of horizontal muscles reveals to be an alternative to resection in strabismus surgery. So exodrift is observed after plication, but similar to resection. So it's a promising procedure. But however, this has certain limitations, especially when we want to do an upshift or a downshift. So coming to exotropia, the PEDIC 8-year outcomes of bilateral lateral rectus recessions versus unilateral resect procedures in childhood basic type of intermittent exotropia are out. And this is basically a extension of the three-year study, which was initially done. And these children were followed up to an 8-year period with the outcomes being a suboptimal outcome of more than 10 prism diopters of exotropia, or a resurgery or constant esotropia. So this 8-year trial has shown that the children who underwent resect procedure has a less chance for a suboptimal outcome. So this is in concordance with a previous study done by Kushner et al. And Sommer et al. With lower follow-up periods, but this is an 8-year follow-up period, and the possible postulation done is the tethering effect of the medial rectus in resection. So that this actually is food for thought. So we need to consider this option in long-term control of intermittent exotropia. So the next one is a refractive change in pediatric patients with intermittent exotropia. So this study, published in JAPOS 2023, showed that there is a refractive change of myopia progression significantly in children with intermittent exotropia. And this basically was a retrospective study which viewed two groups, strabismus children and those without strabismus. And the strabismus children were actually treated with over minus or surgery or observation. And these children were followed up for refractive error change. So whatever be the treatment option which was given to the exotropia children, it showed that there was an increase in the myopia progression. So that is something to think about. So when it comes to near distance disparity, combined recess-resect procedures and true divergence exotropia has been published from AIMS in 2019. So this is a modification of the procedure done by, described by Scott, in which the resection amount is based on the near distance value and the recession amount is based on the near deviation. So this gives promising and results in near distance disparity. So the next would be esotropia surgeries. So high AC by ratios and near distance variance is of constant concern, and classically it has been dealt with Faden or retroequatorial myopexy. But however, it has its limitations of not being adjustable, and it could be technically demanding. Access will also might be a little bit difficult. So 1994, Scott came with the combined recess-resect procedure, which gave an option of adjustable sutures, which were actually proven by other studies, which shows that Scott's procedure is also effective in near-distance disparities. So coming to combined recess resection in convergence excess esotropia with different levels of AC by ratio, this is something to think upon because the same procedure applied to different levels of AC by ratio children showed the same equal results, because this was upon a postulation that palisade endings, which are seen in the extraocular muscles, which will be more deafferenting. When you do a resection, it will be more deafferenting, and this will reduce the centrally driven accommodative effort. So resection and recession is an option in high levels of AC by ratio. But however, this is questionable because even in the normal AC by ratio patients, it showed an effect. And the pre and post-operative convergence and accommodation was also, the accommodation was equal, and it didn't show a difference. So this study did a same amount of resection in all the patients. Pulley fixation is another option popularized by Deemer et al. So coming to vertical deviations, especially the small vertical deviations, they are of a problem creating variety because small vertical deviations are troublesome, and prisms will be difficult, especially in presence of torsion. Botulinum toxin can cause an overcorrection and surgical dosage could not be predicted. So Brodsky has come up with a temporal slant recession of the inferior rectus for small angle of vertical strabismus. It's been published in 2023. And this shows effective treatment for small vertical strabismus of approximately 6 prism diopters. So this is the slant surgery. But the muscle slack theory has not been completely proven because sarcomere remodeling happens within few weeks. So that might negate the slacking. So still needs to be contemplated. So graded vertical rectus stenotomy has been described previously itself, which corrects up to 10 prisms of vertical strabismus. Inferior rectus tucking has been compared to superior rectus recession and posterior fixation suture, especially in the treatment of dissociated vertical deviation without inferior oblique overaction. So these are two patients in which I did inferior rectus plication, which gives good results. This is a Helveston syndrome in which bilateral recession with SO weakening and inferior rectus plication was done. These are the pre-op and post-op. So this was another patient with dissociated vertical deviation and consecutive exotropia who also did well. Minimally invasive procedures were described by Mojon with different surgeries, and it was popularized by Wright with mini plication and mini tenotomy. Paralytic or restrictive strabismus, teprotumumab shows promising results in thyroid eye disease related strabismus, which shows an improved vertical movement and ocular motility according to this study published in 2024 compared to the horizontal deviation. So these are medial transposition of split lateral rectus, which has been augmented by sutures given in different publications. And Nishida procedure has also been implicated in exotropic Duane's retraction syndrome. This is a recent publication. So this is a modified Nishida done for a lateral rectus palsy, which showed considerable improvement in movement. And the last one would be a loop myopexy for heavy eye syndrome with intraocular lens implantation, which has been discussed and published extensively. This is an alternative of Jensen's procedure, which has been described for high myopia and esotropia fixes. Now, coming to a last topic of a less discussed topic is exotropia hypotropia complex in high myopia, which has been published in 2013. So this is this causes diagnostic dilemma, and we need to carefully evaluate these patients before going into treating these patients, because otherwise we can come to a wrong diagnosis. So thank you for your patient listening. And
thank you, Dr. Lakshmi. That was such a wonderful talk. Very nice. And at least for people like me, we should hear it once more to even understand the whole thing. Very nice. I'll ask a basic question before Murli takes it on. Now, should we ask Dr. Meenakshi? She's there with us. Dr. Meenakshi, now, since different studies tell different success rates for recess, resect, and bilateral recession, so how do we reconcile this disparity?
Usually, when you go for recess resect, if it is amblyopic eye or there is no vision, you can go for a recess resect. Otherwise, depends on the case-based. It is more individually case-based. This thing, whether you go for a bimedial recessions or bilateral recession. Because when you do a bilateral procedures, we prefer to do under a general anesthesia. That is of one. And recently, we are going more for plication than resections. So a lot of botulinum toxins we have also used in COVID. COVID, we had a lot of cases where they had acute onset EP, and they all recovered very well with botulinum toxin. So it does have a role, but we have not tried in congenital EPs because of short duration of action and all that. But all these COVID cases, they recover. That is the thing. And we do all the split tendon for bringing the lateral rectus up to the medial side. But it is not easy technique. It takes a lot of time consuming, and bring it forward, split it, and bring it to the other side. It's not so easy always. So it takes a lot of time. Thank you, Lakshmi, for bringing out all the recent these things and the recess and recession technique and all that. So slant, we are now only doing few cases. We have done slants. So one case we developed torsion also, so we had to redo it, and that is also an.
In the study, I think they have done temporal slant recession because they had extortion to start with.
Yeah.
So I personally don't have much of experience with slant procedures, so we'll see.
Murli, anything to add?
Yeah, I want to ask the panel, and Dr. Lakshmi presented a study where she showed that the type of treatment doesn't really influence myopia progression in intermittent exotropia. That is, even over minus lenses don't seem to be causing myopia progression. So how many in the panel, Dr. Jaspreet, Dr. Virender, how many of you actually use over minus lenses in intermittent exotropia?
Yeah, can I answer that first?
Yeah.
Yes, yes.
So I use it in selected cases, but I do use it. And I have found reasonably good results for controlling them. Basically, just a time gap before you would require to do surgery. It's not you can say a curative thing, but getting a good measurement so that the children become cooperative without losing their binocularity. Yes, I do prescribe them over minus lenses in these cases, in some cases. Especially if I find it's very difficult to measure the AC by ratio in children. So especially if I find there's a difference between the near and distance, if they suspected high AC by ratio, probably those are good candidates. But in my practice, I use them in certain patients.
Yes, I think we'll go on to previous speaker. Thanks a lot, Dr. Lakshmi. Dr. Arun, are you ready?
Yes, madam. I'll start.
Yes,
In case I'm not able to get the full screen, I'll present like this itself.
yeah, sure.
Is it visible, madam?
It's visible. You have to go full screen if you can.
That's what I have. In my laptop, it is full screen.
Full screen now.
Okay,
Yes.
thank you. So sorry for the delay. So I'll be talking basically about amblyopia. So amblyopia, as we know, is a disorder of the neurodevelopment which results from the inadequate visual experience during the first few years of life. And it's one of the most common cause for monocular visual impairment. Appropriate visual stimulation, including clear retinal images for each eye, is necessary for the normal visual development, and anything which interferes with this normal development will result in amblyopia. So patching for amblyopia was started with this gentleman as per the history in the 9th century, and still that has been the gold standard for amblyopia therapy. So coming to the advances, I would like to differentiate the advances into the advances in the screening for amblyopia and advances in the treatment for amblyopia. So advances in the screening, the visual acuity testing has been the gold standard for screening for amblyopia. However, majority of the children will not be able to read these letters and numbers, so they will not be able to. Sorry, that's another problem. Yeah. So that's why the importance of automated devices. So there are some automated devices like this plus optics and Welch-Allyn instrument, which aim at detecting the risk factors of amblyopia, like the refractive errors and the strabismus. Whereas the recent advance in that is something called the binocular retinal birefringence. So this retinal birefringence scanning takes advantage of the unique architecture of the human fovea, which has its radial organization of the Henle's fibers. So because the Henle's fiber is birefringent tissue, a spot of polarized light scanned at an annulus of 100 Hertz during the central steady fixation will result in a frequency doubling. That's a 200 Hertz will be the dominant signal in the returning light. So there is an instrument called as a blink, wherein you can, if the fixation is unsteady or eccentric because of amblyopia, there will be little or no birefringence, and because of that, there is no 200 Hertz signal in the retaining light. So this blink instrument uses this principle to screen for amblyopia. Coming to the treatment of amblyopia, basically the treatment is divided into monocular therapies and binocular therapies. Monocular therapies has in the standard treatment protocol, and in that the only advancement is use of this occlusion dose monitors. So there are sensors attached to the backside of the patch so that you can monitor the compliance, because compliance is a main issue with occlusion therapy. Coming to the binocular therapies, because nowadays the recent thinking is the amblyopia is a binocular disorder, and basically the interocular suppression plays a major role in suppressing one eye, leading to amblyopia. So binocular therapies can be divided into two categories: the perceptual learning and the dichoptic training. In the perceptual learning, it's based on the principle that practice makes the man perfect. So if you do a task repeatedly, then you become perfect in that particular task. And these are the few devices which are available for based on perpetual learning. That is the CAM, that is the oldest of the available instruments. And we have the adaptive optics perceptual learning system and the Gabos patches. The problem with this system is the boredom, because you have to do the same task every day. The child gets bored and may not cooperate for training. The compliance might be poor. And second thing is the improvement, whatever we achieve, is specific for that task and may not transfer into the day-to-day tasks. And this is available in our country, the Revital Vision, and personally have no experience. If any of the panelists have experience, I would like to have their opinion on this therapy. Coming to the dichoptic training, which is more popular and more widely used nowadays. So basically, unlike in perceptual learning, where the single vision percept is administered to both eyes simultaneously or under monocular viewing condition, in dichoptic, you present independent stimulus to each eye. So the image shown to the amblyopica will be of a higher contrast than that shown to the normal eye. So as the patient's developing binocular vision improves, the contrast difference between the two eyes is gradually reduced, so that potentially you reach a point where there is no difference required, and the visual acuity gains will follow the improvement in the binocularity and the contrast sensitivity. And dioptric treatment are usually done with the help of red green glasses or Polaroid glasses. There is a game called this Dig Rush. So basically, this uses the red green glasses. So this game consists of miners digging for gold. So patient has to use a finger to manipulate between the both the miners and their surroundings to dig for gold and return it to the cart. And there are a lot of obstacles like the fire, lava, and the monsters. So basically, the reduced contrast elements, that's the gold and fire, are seen by the fellow eyes, whereas the high contrast elements like the miners and the monsters are seen by the amblyopic eye. In order to succeed playing in this game, the child has to use both their eyes to see the respective game components. So the amblyopic eye contrast remained at 100%, while the fellow eye, the contrast started at 20%. And as the performance increases, we increase the contrast in the fellow eye. This is another available therapy for the dioptric trained, the EYEEDU, the interactive binocular treatment. So again, it presents fine movable stimulus to the amblyopic eye and fixed targets or background to the dominant eye. Shows half of the image to one eye, each eye simultaneously, and demonstrates the identical images to both the eyes with small retinal disparity. So this is the EYEEDU system. There is also something called as Occlu tab or Occlu tab, which is also uses the neutral density filter. It's based on the same principle. This is how this Occlu tab looks like. And this is a more popular dioptric treatment, the Binocs or the Amblygo. So basically here it presents the contrast adjusted images to the two eyes, with the dominant eye receiving an image of a lesser contrast than that of the amblyopic eye, similar to the other this thing. So this contrast differentiation removes the interocular separation in the ocular dominance columns in the amblyopic eye, resulting in sustained visual gain. So basically, this works on non-strabismic amblyopia. It doesn't work for a strabismic amblyopia because, again, it requires a binocular vision. A child should use both his eyes to get the improvement. So this is how the binocular Binocs therapy works. And more recently, we have our own Dr. Santan Gopal sir, who has innovated this wonderful device called the Orthoptic, which basically it's a magnocellular stimulator. So this removes the foveal suppression through the top-down impulses to the visual cortex and thereby improves the visual acuity and stereopsis. So mechanism of this Orthoptic device basically can be explained on two processes, which increases the top-down impulses from the posterior parietal cortex to the V1 area. So one is the magnocellular stimulation, and second is the stimulation of the attention mechanism. So there is something called as the overt and covert attention mechanisms. When the patient, basically this has a screen which has some LED lights in different directions. And in the first set of exercises, what happens, the patient detects the light is coming in different directions. So patient, just like in a Humphrey visual field where you have light coming from different directions, the lights will come from different direction. And the patient detects and point out to the light on this board by altering the gaze. And this is called as the overt attention mechanism. And in the second part of this exercise, what he does is the patient will fixate on the central light, and then he starts counting the peripheral lights when the light comes from the periphery. This is almost something similar to the Humphrey field analyzer. Yes, sir. And this is the covert attention mechanism. So both these in turn will stimulate the occipital cortex via the top-down impulses. And the PPC is the critical center where the attention mechanism and the saccadic eye movements node of the cerebral cortex, and exerts the top-down control over the visual acuity. So here first the stereopsis will improve and then the visual acuity will improve. And there are also the medical management, the pharmacotherapy. A lot of drugs like the levodopa, carbidopa, and the citicoline has been tried, but I have very limited experience personally with this. And in conclusion, amblyopia is just not a poor vision in one eye. It affects the overall quality of life of the child. And all efforts should be made to diagnose it early and institute possible modalities of treatment. And in my opinion, binocular treatments are going to be the future of amblyopia therapy. Thank you.
Thank you very much, Dr. Arun. That was a very crisp talk. So, Dr. Veena, are you there with us? Dr. Veena?
Yes, madam, I'm here.
I'll just ask one basic question before Murli takes on. So what is the risk of amblyopia recurrence after dioptics? Right.
I don't have much experience with dioptic therapy, madam. We do give patching atropine and binocs we have tried. But recurrence we have to yet to see, because for the past 2 years only we are giving binocs also.
Dr. Jaspreet?
Yes, so it's still in its infancy. I mean, probably they have the 1-year results where they've shown really good outcomes in these patients. But if you see the, you can say Western literature, probably of very few papers, for a period of 3 years, there was recurrence. So until we have more papers, more literature, probably we'll have to still depend on what the outcome is, because short term versus long term, and as you rightly asked the question, what is the risk of recurrence? There is.
Oh, I would like to just pass a comment on this, madam. Recurrence is definitely there in dioptic treatment, but the importance is, like, I have seen many children who have recurred, but once you redo the treatment, again the improvement happens. So since this is a very non-invasive method of treating, whenever the recurrence is there, say after a year or 2 years, you can always probably redo the treatments. And as long as it is giving improvement, I think it's definitely helping the child.
I think just to add to this discussion, the dioptic therapy is improving, and there are concerns about that, how long the therapy will be effective. So as of now, nobody has a clear-cut guideline. Most of the studies which are there, they look at for a period of 16 weeks or 24 weeks as the maximum. But long-term outcome, how much it stays, everything is still not clear. In fact, there are studies which tell that over the long term, the visual acuity does go back in case it is not supported. So all this will come out through proper randomized controlled child studies. And the PD group studies which were there, they actually, unfortunately, did not show the same level of improvement with dioptic therapy as is shown in the smaller case studies. So at this point of time, dioptic therapy really appears promising, but let us wait for bigger studies to come up and then see the results over a period of time. We'll await the results of these RCTs.
Madam, I would also like to add, like, basically, I think they market a lot about it being something more than patching therapy. But honestly, for some patients, I mean, most of the patients, I haven't had any patient whom after we have reached a peak for patching and we put them on these dioptic therapy, we get any extra improvement. I really haven't seen this. The only patients where it has been effective is moderate amblyopes and anisometropic amblyopes. That also if you haven't patched. If you compare an anisometropic amblyope who improves with patching and with dioptic, it is almost the same. Is what has been my experience. So my excitement about that therapy is actually gone down after after the last year or so, I would say.
That's the cost factor.
Could
is
I
there.
add?
It is still the gold standard. I mean, for anisometropic amblyopia, probably they would improve with glasses only in the initial setting and maybe a patching little bit.
Exactly.
But the main where we require all these therapies are strabismic amblyopia, which are very recalcitrant to treatment.
But they don't improve, sir. I mean, I have tried it after a
None of these studies, they have included cases of strabismic amblyopia. They've just included few mild cases of strabismic or mixed amblyopia or anisometropy.
No, for that matter, I also wanted to ask a question. In the strabismic amblyopia, Dr. Virendra or Dr. Prachi or Dr. Shubhangi, have you actually gone ahead and surgically corrected and tried administering this dioptics as the...
Yes, I have done it.
Yeah,
but I haven't found any excess.
And did you see an improvement? Because in refractory amblyopia, I mean, I'm not very sure this dioptics does a good job, to be very frank. Refractory.
Exactly, same experience. So it doesn't. I mean, whatever improvement you have got, suppose a child was 2 meters and you have got an improvement till 636, they just stay at that. There is no extra improvement.
No, but
I am a believer that we should do an amblyopia treatment prior to the surgical correction. Once the eyes are straight, the motivation of the parents to do the amblyopia treatment also goes down.
No, but
No, madam, my question was,
dichotic
my
treatment
question,
doesn't work when the strabismus is there.
yeah, no,
Yeah,
what
so you can't administer that. That's true.
No, what I exactly wanted to ask was, you have a strabismic amblyopia that is refractory. So has somebody tried surgical correction and administering dioptics after the surgical correction? That was what. So you've tried patching. So patching has not has leveled off the improvement, and has any in the panel tried surgical correction for this refractory amblyopia and administered dioptics? And
Yes,
what
sir,
was
I have tried. I have tried, Dr. Murli, that I have tried, but as Dr. Prachi said, not much improvement.
I have also tried in strabismic. It doesn't improve, but it has improved in a developmental cataract, bilateral developmental cataract. I operated at 2 years of age. And the child was doing patching. I think membranectomy was also done in one eye. So that eye, there was amblyopia. So, but they were doing patching very consistently. And in that child, I had actually an improvement. So now 1 year, that improvement is staying with the dioptic stimulation.
That's very surprising, madam, because in my experience, the deprivation amblyopia has been the worst. Does not respond at all.
But she had a membranectomy. It was operated early and membranectomy was done, but definitely improved.
Okay.
Possibly at this point of time, mild to moderate anisometropic amblyopia are the best possible candidates for the dioptic therapy. Others we have to await. Though some of the dioptic therapy manufacturers do claim that it is quite useful in patients where the visual acuity has leveled off in refractory cases. Though in practical experience, we have to take it with a little bit pinch of salt, and more data on that would be helpful.
So thank you so much for the discussion. We go on to our third speaker, Dr. Swati Paliga, who's a consultant cataract, pediatric and strabismus services at our Eye Foundation group of hospitals based at Coimbatore. And she's going to show us a case with a twist. So on to you, Swati.
Good evening, everyone. Today, I would like to present a case, which is the management of a large consecutive hypertropia after a superior oblique tenotomy. And thank you to Dr. Muralidhar for sharing this case for us for discussion at this forum. So superior oblique palsies after superior oblique tenotomies, as we all know, are notoriously difficult to manage. And today, we would like to describe a successful management of such a hypertropia by re-anastomosing the superior oblique muscle, nasally anteropositioning the inferior oblique, and recessing the contralateral inferior rectus. And our case is going to highlight the difficulty in management of such a case. A 25-year-old male patient presented to us with a large right hypertropia, having undergone 2 strabismus surgeries elsewhere. There were no records at all of his first surgery, but we did have records of his second surgery, which mentioned the procedure having been done as an inferior oblique anteropositioning. And the notes mentioned that the patient had an iatrogenic right superior oblique palsy as the preoperative diagnosis. He had an uncorrected vision of 20/20 in both the eyes, and he had developed right suppression, which we noted on a Worth-4 dot test. Our squint evaluation showed that he had a right hypertropia of about 25 prism diopters in primary position, with an exotropia of 20 prism diopters. On his left gaze, the right hypertropia increased to 50 prism diopters with 20 prism diopters of exotropia. On right tilt, there was a 40 PD R by L with an exotropia of 20 PD. Left tilt, the R by L reduced to 6 prism diopters with a 14 prism diopter exotropia. He had a right inferior oblique overaction of +4 and a right superior oblique underaction of -2. Along with this, the fundus examination showed excyclotorsion in the right eye, and the remainder of his ocular examination, anterior and posterior segment, was largely normal. So we then explored the eye under general anesthesia, and these were our findings. We noticed that the right superior oblique was located on the nasal side of the right superior rectus, and it was attached to its original insertion by a pseudotendon. So this is an intraoperative photograph. You can see that the forceps is holding the superior oblique tendon. And from there until the globe, you can see the pseudotendon extending. The muscle that is hooked is the superior rectus. So this is probably the likely result of a previous tenotomy. So we proceeded with the surgery, which involved excision of the pseudotendon, and the superior oblique was sutured to its insertion with 5-0 polyester sutures past 8 mm posterior to the temporal border of the superior rectus insertion. The distal end of the tendon could not be identified. This was then followed by hooking of the right inferior oblique on the temporal side of the inferior rectus, and a nasal anterior positioning was done. Then we moved on to the left eye surgery, which involved a left inferior rectus recession by 2.5 mm, which was placed on adjustable suture, and the left medial rectus was plicated by 5 mm to tackle the exotropia. When the general anesthesia wore off, we noted that the patient had a small residual right hyperdeviation of about 7 prism diopters in primary position. And since the angle was small, the left inferior rectus sutures were tied without any further adjustment. This is his 7-month postoperative pictures. There was a small right residual hypertrophy of 7 PD in the primary position. There continued to be a residual inferior oblique overaction of +2. There continued to be a small superior oblique underaction of -1. The residual right hypertrophy of 16 prism diopters on left gaze, and the patient reported no diplopia, and there was no excyclotorsion on the fundus examination. This is the closer view of the primary position and the left gaze, which was the angle of the most of the largest squint, and the patient was very happy with his cosmetic outcome. So let's move on to the discussion. So superior oblique tenotomy has been a surgical option for multiple conditions such as Brown syndrome, in inferior oblique palsy, and in A-pattern strabismus with the superior oblique overaction. Now, the results tend to be very variable. In lucky cases, we end up with an optimal correction. There could be an undercorrection, which often may not be very problematic, but sometimes we end up with bothersome overcorrection due to a superior oblique palsy. So what are our management options for such a hypertropia after a tenotomized superior oblique? The first thing would be, one of the options would be the retrieval and reanastomosis of the superior oblique tendon over a 240 band, or inferior oblique weakening on the same eye, or contralateral inferior rectus weakening. So we are fortunate in the fact that the attachment of the superior oblique sheath to the tendon and to the globe often prevents excessive retraction of the superior oblique, which means that there is some residual superior oblique action even after a tenotomy, and this also provides an opportunity for retrieval. So our patient had to undergo all the modalities to try and correct the right hypertropia. The reduction in the excyclotorsion of the right eye indicates that there was successful resuturing of the superior oblique tendon to its insertion. We could not trace the distal end of the tendon, so the fan-shaped insertion of the superior oblique tendon could not be replicated, and he continued to have residual superior oblique underaction and inferior oblique overaction. So our take-home message is, this case report highlights the grave complications of superior oblique tenotomy, which can cause a consecutive hypertropia that is often difficult to reverse. Even though the procedure primarily done was only a tenotomy, but the reattachment of the superior oblique alone is often insufficient to restore the ocular alignment. We can have both early and late undercorrections, and multiple surgical procedures are often needed. Thank you.
A lovely presentation, Swati. Murli, could you take the question?
Yeah, I had a question for the panel, Dr. Virender, Dr. Jaspreet. Of course, we rarely do the Burke stenotomy these days, but we do encounter surgeries done by the other colleagues. One more condition in which we can encounter this kind of a problem is after chicken suture or after a number 240 band placed for treatment of a Brown syndrome. So sometimes this results in a recalcitrant palsy. So the obvious treatment, of course, would be to explore and try to reanastomose and make good the anatomy when possible. So my question is, what would you do if you are unable to find the end of the superior oblique? Have you encountered this after number 240 band? In fact, I have switched to Z10 and lengthening after I read about these case reports of this thing. In fact, Sue's paper on the chicken suture, adjustable chicken suture for superior oblique lengthening in Brown syndrome showed a 25% incidence of superior oblique palsy over a period of time. So what are your surgical options in case you are unable to restore the anatomy in this case? Dr. Virender, Dr. Jaspreet, or Dr. Veena?
Can you just unshare the presentation?
Swati, can you unshare?
Stop sharing, Swati.
Stop sharing. Yeah.
Yeah, no doubt. I mean, these are tricky situations, and I mean, if it's possible that superior oblique tenotomy was done, and if the adhesions with the superior rectus are gone, probably it's quite difficult to get it back. But if you could get it back, probably you could just try for a plicated superior oblique rather than just attaching it to where it could be. So that would add to a little bit of tightening effect. And yes, because of such a large extortion, probably in this case, nasal transposition was what I would have done in these cases as well. With the silicone expander, probably there are, I mean, reports that it could land up in a superior oblique palsy, but obviously those few cases which I have done probably haven't had this problem. So of course, even for Browns, I would do I've shifted to a split lengthening, as you were saying.
So I have also done some cases of.
Any other thoughts?
I have done some cases with the silicone 240 bands and chicken sutures, but I have not found any overcorrection sort of with these cases. And in the situation, if you can't find the muscle, then obviously we need to do the other, as you have done rightly, the nasal transposition of the inferior oblique. So that would, I think that's what I thought, that the excyclotorsion also could be reduced because of nasal transposition of inferior oblique.
We have similar experience. I have operated one case a couple of years ago where the superior oblique was operated for a suspected Browns, and after that the muscle was adherent over there, but I had been able to dissect and separate the muscles. In fact, for the hyper in that case, actually I did the SR recession and it worked. The other case was after the superior oblique. That patient actually had a superior rectus transposition, and it had become so adherent that we could hardly dissect out the muscles. So we went ahead and did the inferior oblique transposition. So where it is not possible, it can be managed by working on the antagonist muscle is definitely one option. The other important point might be that if we notice this change, if we try to operate within a short window, like 1 week to 10 days, might be up to 2 weeks, it might still be feasible to find the planes. But later on, it might become very difficult to operate on these patients.
Thank you. We go on to our next speaker, Dr. Vimla Srinivasan, who's a developmental therapist for neurologically impaired and with learning disability, and very much sought after person. And she's the right person for this very interesting talk on managing cerebral visual impairment. On to you, Dr. Vimla.
Hello.
Yes, we can hear you.
Yeah. Good evening, everybody. And thank you, Dr. Chitra and Muralidharan, for giving me this opportunity. So, having worked with children with cortical visual impairment for so long, I'll just share my experience with you. That's how to manage the children visual abilities. So what is CVI? I don't have to tell you what CVI is. So you all know it is the damage to the brain or the visual pathways and affecting the perception, cognition, and visual guided movements. So during in the womb, or it can be genetic soon after birth, or even later on. So thanks, Dr. Arun, you put it in a beautiful way in the brain, making us understand visually very clearly what is affected and which part of the brain is affected and what all will be affected. So I put it in a different way, which is a little more complicated. So visual function, what does we see? We see clarity, contrast, clear, and we see moving object near and distance and attention, seeing details, and we learn from that matching, sorting, categorizing cognitive abilities and visual reach also. And from as a child, we go from 3D to 2D, object to picture and symbol level. And eye-hand coordination is a very, very important task in the whole developmental stage. And we all know that object permanence is one of the visual and cognitive ability. And visual perception skills, many part of the brain is affected, many of these could be affected. So we get children with school complaints, not good attention span, and not able to copy, drawing, coloring, and struggling with reading and missing words, line, and then value of counting the numbers, and 2-3 images is writing within a box or lines, and they get visually fatigued, and sometimes they put their head down or to one side and difficulty going down the steps also. And we also see the complaint of seeing the object or person pointed to in a crowd and recognizing people and object also, and visual spatial skill. And these children may not hold the pencil properly and able to see small print, and some of the other motor skills of buttoning and using scissors. And in writing also, they miss their lines in appropriate size also, and their visual performance vary, and we don't get joint attention. So because by sound and touch, they may get visually distracted. And concerns from the parents are, when they come very young to us, not looking at the face or recognizing any family members, and there is a development delay in one or more areas, and looking at the head tilt, they have a squint, not reaching to toys or holding the bottle. Most of the children come to us with light gazing, no fix and follow, because there is no proper sensory integration. So now we come to goals of CVI, or managing. How do we manage CVI? To support the access to learning by supporting use of existing vision, developing existing vision and visual potential, developing compensatory skills so that overall development is not limited in all areas of development. For this, we need a very, very, very proper assessment of children with cerebral visual impairment. What are we going to do? First, see, do they use the vision to explore, learn from their environment, and plan, then executing their plans in the context of daily living activities? And what do they see? The appearance of the eyes, as you all we must see, and then the blink, pupil constrict, fix and follow is maintained, and follow gaze shift to light or object of 6 inches, because these are all very young children I'm talking about. Check the fields, eye-hand and eye-foot coordination, visual preference, size and the distance. And then what helps the child to see? Is it light, is always light gazing, or glittering object, or high contrast, or single color object, moving object, or object that makes sound? What are the visual abilities we need to check? Is the near and distant acuity, visual field, contrast sensitivity, color and light perception, oculomotor control. Is the vision always visual, is available for learning? So how does the visual function happen? Is the gaze maintained? Most of the children who come to us just see a flick of a second. So they don't look at the object or whatever we are going to present for a long time. And the fixation we need for 3+ seconds to see what it is clearly. And are they reaching? And what attracts and maintains and distracts the visual attention? Sometimes the other senses attracts the vision and at the same time distracts the visual attention also. So auditory, tactile movement or clutter. Visual alertness in different position, because many of the cerebral visual impaired children are multiple disability with visual impairment. They have motor issues, speech. So we test the visual acuity with LIA checking acuity cards and contrast sensitivity, near and distant. And if what does the child see? If the child is not able to see the acuity properly, we give the magnifier also to see how much the child can read. Why should we measure the visual acuity? Is the function of refractive error and accommodation, as one of the measures useful is determining literacy medium. So what does the child see? It's a small object. It is for the children who does not go into the real acuity charts. So small children, what do they see? So it's called the resolution acuity, and it's not the reading acuity. So we see with Leah gratings and teller acuity cards. And in children with severe visual impairment, grating acuity is only can be useful, especially if it is not possible to measure the recognition acuity. So these are how we see the Leah paddles. And these are the other charts which is used for children. And this is the contrast sensitivity. And this is the Lee puzzle, which gives us whether the child is able to match the colors, the shapes, or the direction of the presentation. And this is from color we go to black and white, and then to 3D to 2D. So this is the line test. These are all some of the tests we do. And reading acuity we do with one line, single line, and then we go on to 50% and 25%. And most of the children can do the single line, but not the crowded 50 and 25%, which helps us to understand that the child will have difficulty in reading the book. So from what are the developmental stage the child has achieved? Because this is very important. When the child come to us, they are mostly in a lying position to see the child is looking at the light. So what do we do? Just making them look at the light. It's only the fixation on the light.
1 minute more?
Yeah. 1 minute more. Oh, I have a lot. Yeah. So these are the many of the position we use, and every child is unique, and we use these all contrast and the mirror and different type of sound making toys, and what are the good position they use, and is the auditory brings the visual attention, and is the child able to communicate, and so this also helps us because most of the children who come to us does not have a gaze shift. Gaze shift is very important because the child needs to communicate to give us option, and these are the communication chart we use. And one I really want, this is for orientation and mobility, and this child who came, I want to just give one case study. Vinodini, who came to Vidyasagar, no fix and follow to light, mild pallor, hypoxic damage to posterior visual pathway. So review after 3 years, and she was a preterm birth cry present. So, and she's a spastic quadriplegic and no mobility and also leg scissor. So when she came to us from light gazing, she came on to identifying the shapes, and then she's also asking whether it is correct, and then going on to line drawings and with sight words. And then she started going to inclusive school, where we modified the curriculum for her. So she used to answer even the stories in a sequencing way with pictures. And this is the embossed system where the child learns about the circles and the lines. So what attracts what? This is the communication chart board, and it is a must that the child should how to present. What does the child see? Presentation, please place it in the field of vision, and also slant, or is the gaze shift from vertical or horizontal? Should they need contrast? What is the size of the picture we are going to give? And then what is the child going to reach? Eye-hand coordination is a very, very important thing. And communication, because we want a child young, we want them to tell what is happening to them, prepare for an activity by saying all the activities name and the object they use, and improving the language skills also. Is it over?
Yes.
Yeah, sorry, I had missed so much because the time was limited. Yeah.
Yeah, thank you. Thank you so much, Dr. Vimla. It was such an interesting talk and such a great insight you brought us into this. So this question is for expert panel and also Dr. Vimla. What is the role of the optical correction and low vision aids in children with cerebral visual impairment?
Yeah, we do give the correct.
Stop screening. Stop sharing. I'm sorry.
Yeah.
Yeah.
We do give the corrections like for the school going children, we give that line typo scope, and then we give the binoculars or the whatever it is. I don't know so much of it. That's why your optometrists come to help me, to be with me, to say what all the things which will help them to do better visually. Yeah.
Dr. Meenakshi?
Thank you, Dr. Vimla, for highlighting the importance of rehabs and how to do a vision assessment. So all these children in general have accommodation will be very poor in them. So that is very important that a small plus correction can make the child focus for the near. So a lot of time we miss that. We think that like a normal child, they have very good accommodation, which they will not usually have. So even a mild hypermetropia, or you can even give a small plus and they do better, and you can get a better focus for them. And the social recognition, smile happens, which we have seen many times. So this point we should remember that give correction, unlike other children.
Mostly it is +3. They are given +3.
Yeah.
Because young children always play in near their field of vision, and it helps them to see the things better.
And the other thing is, most of them have reading difficulties or writing difficulty mainly because of the inferior field defects they have. So that also we should, it can be sometimes very subtle, which can get missed, and the complaints can come from the school or from the parent that they are studying, they are able to listen, and whatever amount of oral activities they will do, all the reciting, everything they'll do, but in writing they'll have difficulty. So whenever somebody has a difficulty in writing, we have to find out and go back to the history and see.
And because we all feel that when we do the visual perception skills, they have a problem in visual copying. So many of them, because they are not able to, even if they have given a corrective glasses, they are not able to copy from the board because they have some of the perception problems, form and copying problems. Yeah.
Murli, you have anything to ask before we go on to our next speaker, because we are running short of time? Murli?
Yeah, Madam, I have a question for Ms. Vimla and also for the expert panel. So what is the age at which you start introducing low vision aids to these children, like use of stand magnifiers or cutaway magnifiers or a video magnifier? What is the optimal age that we should get this LVA trial done for these kids?
Anybody on the expert?
So maybe I would like to give some input. So an age would be when it really depends on how much the child is having difficulty seeing it and their baseline visual acuity. But maybe even 7-8 years of age is good enough. But what I'm really seeing in practice is the use of these devices is going down day by day. I think most of them are just switching over to the computers and laptops, which is just easier and a better way for them to function. And I actually have started encouraging parents to make use of these devices to improve their learning. It is it's much easier to just magnify it on the desktop. Their hands are free. They can just read from the desktop and they can read it. So I actually press the parents to get the soft copies of their school books and school curriculum, and otherwise also they get writers and things like that for their exams. So, I mean, that's what I see in practice. I mean, I have hardly ever seen a child whom we have prescribed a telescope use the telescope functionally. It's always there in their bag, but they hardly ever use it. So that has been my practical thing that I see nowadays. And I kind of tell patients to use certain, the apps that are there, speech to text, text to speech. So it just makes their life more convenient and easier, and the learning is much better rather than just pressurizing the child to write, and that's what I am doing these days, basically.
Agree with you.
I also do that.
Problem is only in school. Otherwise, at home, we also encourage what you're saying.
Yeah.
School is the main problem. Telescope, nobody uses. I mean, even if you prescribe, because the field of vision is so restricted, nobody uses it. Yeah.
Thank you.
Can I add just one point in this? Because what I felt from my practical experience, especially in very young children with cerebral visual impairment, what I felt is when you add these activities integrated into the daily activities, especially in the kitchen or in the at home, so that gives actually a better response from the children, like sorting vegetables and just be with the mother with the daily activities. That actually helps them better. And in the same way, mobile use is what I also, because school it's difficult, but otherwise I say that.
Good. We go on to a next speaker. Thanks for the discussion. We go on to a next speaker, Dr. Jaspreet, who's going to be talking on managing strabismus resulting from trauma. So on to you, doctor.
Thank you, Dr. Chitra, for this opportunity for presenting in this pediatric ophthalmology webinar. So I would be talking about strabismus resulting from trauma. And I would just like to make it clear here that I won't be talking about damage occurring because of neurogenic trauma. So it would be limited to direct trauma on the muscle where the extraocular muscles are affected, and that is anterior to the orbital apex. So it's divided into, it's either ocular trauma or it's an orbital trauma, what we'd be discussing in this presentation. So why is it difficult to handle when we have such kind of injuries, when you have strabismus related to trauma? Because there are so many causes of injuries. I mean, it could be a blunt injury, it could be sharp injury, it could be a roadside accident. So a lot of things. And there's so much variation to the severity of the injury. It could be local contusion or an avulsion. So injury directly to the muscle or to the structures around extraocular muscles or to the nerve supplying the muscles can occur because of such kind of accidents.
No, I'm going to manage to get some vegetables.
So it's a complex presentation
Because
of the edema and hemorrhage which occurs when such an injury, when such an accident occurs. So we have to differentiate between the mechanical from the neurological causes. That's very important because the management would differ. And in some cases, the sensory examination may confound a motor examination, and thus it causes a unique challenges in the management in these cases. So what are the strategies for management? Basically, check for any penetrating trauma or a foreign body. That is
Can everybody mute themselves because we are hearing too much background noise? Please.
Thank you. Motor examinations, obviously where the patient is cooperative, and you always do a duction examination, check the saccage if there is a floating or an abrupt stoppage, always check for primary versus secondary deviation, and where possible, try to see for restrictions by doing a forced duction test or a forced generation test. Imaging is a must in these cases. Try to identify injury to the surrounding structures and to the muscle. Reduce the edema with the systemic corticosteroids. This is again a question which comes to your mind, whether it is immediate versus late exploration or repair that is required. But in all cases, try releasing the restriction, reuniting the same muscles, or else a transposition procedure. So some of the injuries which occur due to the when there is an injury to the muscle, probably some of the strabismus which occurs because of muscle injuries is these are minor ones, like muscle contusion. It's basically a direct injury here occurring to the muscle, which is followed by maybe edema or some kind of a hematoma in the muscle belly, which causes a decrease in function of the muscle and a deviation in the opposite direction. So there is most of these cases would resolve spontaneously, but just observation is what is required. Then you have what you call lacerations. Direct injuries with sharp objects can cause lacerations of the muscle. There's a rupture at the site of impact. And yes, in such cases, you have to intervene early. Then you can have disinsertion. So disinsertion is usually, you can say, an injury at the insertion site. So the blunt object, it just cuts the muscle. The muscle does not retract because of the check ligament. So there is still some muscle function which is preserved. So in these cases, obviously, do an early exploration. You don't want fibrosis to occur and reattachment to the insertion site. The next is transaction. So transaction is a complete through and through cut through the muscle belly. So it's a direct injury. It occurs usually with a direct injury. There is a complete width which is involved. The insertion usually remains intact here. The post-duction test, the fourth generation test is negative because the muscle's gone. And the commonly involved muscles are the medial rectus followed by the inferior rectus. So just to demonstrate a case here, what happened was this gentleman, you can see here, he has a right eye exotropia. Now he had undergone a sinus surgery, an endoscopic sinus surgery 4 months back. And after that, he presented with this double vision. And you can see the exotropia here. The movements are fairly good when he's looking to the right, but when he's looking to the left, there is hardly any movement of the right eye, and there is some widening of the fissure as well. So what we did here was, important thing is what happened. We were suspecting some kind of an injury to the medial rectus. The imaging becomes very important for further management. So in all cases, to locate the level of transaction and the muscle, and imaging is required. Sometimes you do a functional imaging to know the contractility of the muscle stump, even after a long period of time, because it can guide us if the muscle retrieval can still be successful or to reestablish the muscle function. The chance of anterior segment ischemia is lower because if you just join the muscle which is transacted, probably it's much better as compared to if you like to do a transposition procedure. So this will also guide you whether if you could do a direct procedure or you would need to do a transnasal or a transorbital approach. But sometimes imaging can be misleading, there is scarring, and the clinical diagnosis can definitely be confirmed only by surgical exploration. So always the surgical exploration is the one thing which you will rely upon. So just to show you that the case which we had earlier, what happens here is we can hook the medial rectus. So the medial rectus here. So we had done the imaging. We found that the transaction is quite posterior. So we tried to do it from an anterior approach and could hook the medial rectus, which is quite thick. And you can see here, it's a thick medial rectus, but then it is attached to the orbital fascia here and the tenons here. Now this patient presented after 4 months. So possibility that such kind of a little adhesion would have taken place. And then we do not have to cut the tissue. It's a blunt dissection which we have to use because we want that maybe the capsule, that the muscle which is gone is maybe in the capsule, the remnants are there. We can just trace those remnants posteriorly and get to the transacting muscle. So always try to do a blunt dissection and be slow in these cases. Don't be aggressive. But we could not find that muscle. What we could find was just a little this fibrotic sheath attached to the fascia here. And therefore we had to leave this muscle and could not get the posterior end out. And in such cases, what we have to do is then obviously a transposition procedure. So we split the inferior rectus and we also split the superior rectus and joint and transpose it in the direction of the medial rectus, and we put a Foster suture there for better augmentation. So this is something what we have to do in the non-table decision. Sometimes you have to do to get the patient in the primary position. Oops. Yeah, so this is another case. You can see here what happens. Again, the left eye medial rectus, if you see here when the patient is looking to the right, it's not moving. So it's when the patient looks to the left side, probably everything is fine. So again, here what we did was a Nishida procedure. And what we could do, the best we could do was get him parallel in the primary position, even though the adduction was limited. So there are different ways to tackle these cases when you have transactions. So the surgical approach, if you have a standard surgical technique, mostly for retrieval of a lost or transacted muscle, it traditionally involves locating the muscle capsule tunnel that passes through the tenon capsule and searching within it. Otherwise, a transconjunctival orbitotomy has been found useful, where the transaction is quite posterior and there is difficulty in finding the proximal end of the muscle. So next comes the flap tear. This is very important here. So what happens is a partial thickness. If you can see here, there is a partial thickness tear here. There is an orbital fracture here. So you can see here the two layers. We have hooked the inferior rectus and there is another layer here of the inferior rectus. So there are two layers, which is what we call, this is the global layer and this is the orbital layer of the inferior rectus. So we have two layers here. Most commonly it is the orbital fracture, but blunt trauma can also cause it. There is separation of the two layers. These are the global and the orbital layers. And what happens is during a trauma, there is traction on the orbital layer. That's the outer layer by the connective tissue by a shearing force. So intraoperatively, what you will find is that there is a segment of
Doctor, 1 minute more.
Yeah, or a tendon is missing with narrowing of the remaining portion. So that's how basically you have to see that there is a flap tear. And it can be a leash phenomena or a reverse leash. By reverse leash, I mean that there's a tear here and the eye does not go down because there's adhesion between the interior part. But if there is a tear posteriorly, then what happens is limitation in the upcase. So that becomes a leash. So this pattern gives you a clue that where the tear is. So all patients with orbital fractures with diplopia receiving fracture repair should undergo simultaneous exploration of the adjacent rectal muscles. If an unrecognized flap is allowed, probably then what happens is the motility becomes more difficult to treat later. So orbital floor fracture is the next common thing. There is a hypertropia because of soft tissue or the inferior rectus entrapment. It may be a laceration or a disinsertion. It is a trapdoor in children and accommodated in adults. CT scan is the imaging of choice here. Regarding repair, the most important thing is there is no consensus in adults, but in children, best results within 1 week. So this is just to show you a patient who had a difficulty in movement of the eyeball on the left side after falling down. So you can see some left hypertropia here. The eye is unable to move down, neither it goes up. So if you see the CT scan here, you can see a little trapdoor type of a fracture here with the inferior rectus and the soft tissue incarceration here. So after the repair, what happens is the first post-op day, the axis is really parallel. There is movement in the up case, and we have a 7-year follow-up here. You can see the movements are fairly good in up case. There is no diplopia, it's parallel in the primary gaze, and the downward movements are fairly good. And if you see the CT scan, such a well-healed fracture with the movement, with the action, with the, you can say, the inferior rectus working in a normal way. So I like to conclude here by saying that determine the condition of the compromised muscle to plan the best management. This extraocular muscle entrapment of flap tears following orbital fractures comprise the most common cause of traumatic strabismus. And the repair of a direct extraocular muscle injury depends upon the severity and the extent of injury. Always, the first attempt should be to reunite the transected muscle. If not possible, then probably a transposition procedure. Preoperative imaging should be decided based on the type of injury. And in orbital floor fracture with muscle entrapment, where you have positive FDT and OCR, that is the oculocardiac reflex, urgent intervention is required. Thank you for your attention.
So in continuation with your wonderful talk, would you do this lid split approach if it's a sharp injury for retrieving the superior rectus muscle?
I mean, it depends again, as I told you, it's imaging would decide upon that. So if you're going through doing the anterior route, probably if it's anterior, yes, you could do that because it's always easier. But then if it's posterior, orbitotomies have shown, you can say these trans-lid approaches, transconjunctival approaches have shown that even in those cases where the anterior approach is not possible, they could get the muscle out in almost all of their cases using the other approach. So yes, that is depending upon the imaging, you could decide upon that.
Murli, you have a question before we go on to our next speaker. Wonderful talk, Dr. Jaspreet. So many wonderful case examples.
Thank you.
Yeah, thank you, Dr. Jaspreet. So I have a question for you and Dr. Virender. Any experience with the orbital endoscopic approach of retrieving lost muscles?
No, not really directly. It's mainly literature based, but at the same time, combined approach along with the orbital surgeon that I have tried a couple of times, where we have been able to, retrieve the fragments, and basically the muscle becomes easier to approach by taking their help. But most of the time, I think what Jaspreet has highlighted in beautiful talk is very helpful.
Yeah.
Looking at there are cases where you may not be able to find for sure that the muscle segments are there, but attaching to the fascia also helps by actually in the later period helping with the improvement in the motility. So if you have not been able to find anything, in a transected muscle or lost muscle, but you can follow up and see that the muscle sheath is possibly there. Attaching it over there possibly does help in those cases also, as the worst case scenario.
Especially in inferior rectus trauma.
Yes. Yes.
Thank you. We go on to our next speaker, Dr. Shubhangi Bhave, who is a consultant ophthalmologist working on squint, cataract, and oculoplasty surgeries at Drishti Eye Clinic, Nagpur. And she's going to be talking on managing large angle strabismus, non-recurring sixth nerve palsy. So on to you, Dr. Shubhangi. I think we should mute ourselves because the background noise is coming in. I already know somebody is going to buy vegetables.
Thank you, Dr. Chitra and the Eye Foundation and Dr. Murli for asking me to be a part of this wonderful treatment, which was so wonderfully started by Dr. Arif Khan. I would be speaking on non-recovering sixth nerve palsy. So a sixth nerve palsy is probably the most commonly encountered cranial nerve palsy. It could be congenital or acquired. And acquired are due to various diseases. Recovery generally occurs in 6 months. When recovery doesn't occur after 6 months, we label them as non-recovering sixth nerve palsy, and then probably the treatment remains as surgical. Just one point about differential diagnosis of a sixth nerve palsy is whenever there's a sixth nerve palsy, the most important thing I think is the amount of deviation is corresponding to the loss of movement. That is, as you can see, in a sixth nerve palsy, there's a grade 4 abduction deficit with a parallel or equal amount of EZO in the primary, as against a Duane's retraction syndrome, where the eyes are practically straight with grade 4 abduction deficit. And in Duane's, the saccades will be abrupt, whereas in paralytic squint, they'll be floating saccades. Now, these are the various procedures for the sixth nerve palsy. I'll just highlight my points by presenting 3 or 4 cases. So the first case is a 7-month-old female present with deviation since when she was 3.5 months. Right eye was esotropic. She had prominent epicanthal folds more on the right side with medial ectropion on the right side. There was an abnormal head posture to fixate in the right gaze. There was a large right esotropia and right abduction deficit I wasn't going beyond the midline. So we labeled it as congenital sixth nerve palsy. The MRI brain was normal. So the first surgery we did was a bilateral medial rectus recession. Right eye did more than the left eye because right eye MR was very tight. We also did a probing on right side because she had watering on the right eye. After 3 months, the head posture was better, but there was still some EZO and right abduction deficit. So the second surgery which was done was a transposition procedure to the right lateral rectus. Now, post-operatively, the eyes were straight and we could achieve some degree of abduction after the second surgery. But after 10 years, when she was 10 or 11 years, she developed some exotropia. And there was a right adduction deficit too, indicating an overcorrection. Here now, since the right eye, I had operated both the muscles. So what we did was we operated her left eye. The lateral rectus recession was done and left medial rectus was advanced. And at 1 month post-op, the eyes were straight. There was some abduction deficit in the right eye. And this is at present, she's a young girl of 18 or 19. Her eyes are quite straight, though her medial ectropion remains. So then I'll be presenting just 2 cases, 2-stage versus a single-stage approach. Now, this was an old case of mine. She was an elderly lady, had a road traffic accident and had a double vision since 1 year. She had a left 6th nerve palsy. You can see the large esotropia in the primary position and abduction deficit, which was -5. So the first procedure we did was bilateral medial rectus recession, which corrected significantly the primary position esotropia, but abduction deficit remained, and she had significant diplopia in the left gaze. And so the second surgery was planned after 3 or 4 months. We did a partial tendon transplant to left lateral rectus because she was an elderly lady and also had hypertension. So we didn't want to do a full tendon transplant. And after the second surgery, the abduction improved. Now, this was a similar elderly lady who had come with a right lateral rectus palsy again after trauma. And she had a grade 5 limitation in the right eye and grade 2 limitation in left eye. So it was asymmetric bilateral palsy. But here, thanks to the Nishida's procedure, we could manage her in 1 stage. We did a bilateral medial rectus recession with Nishida's procedure to the right lateral rectus. And so in one sitting only, we could correct the esotropia. You can see a marked improvement in the head posture and some improvement in the abduction. And the primary position diplopia was corrected. So this is a small video of, Nishida's procedure. So in Nishida's procedure, it is no cut, no split type of transposition where we don't need to cut or split the muscle, and it spares the anterior segment circulation. So we can combine it with the recession of ipsilateral antagonist muscle. Here, this is the superior rectus in which the suture is taken on the lateral 1/3. I use a 5-0 ethibond in these procedures. And then the superior rectus is then tied about 8 to 10 millimeters in between the SR and LR in the superotemporal quadrant. So by doing this, we are transferring the vector force of the superior rectus towards the lateral rectus, enabling the lateral rectus to move. Can be also done for superior rectus palsy in wherever we need the help the paralyzed muscle. So similar, yes. So similarly, the inferior rectus is also hooked. And we are doing the same steps on the inferior rectus. The dissection has to go back till about 9 or 10 millimeters to give us good result. It is a strong procedure, corrects about 30 prism diopters of deviation, and the procedure can further correct by either recession of the contralateral of the opposite muscle or Botox to the opposite muscle. This is the last case. It was a 23-year-old. He was operated for juvenile angiofibroma and had a 6th nerve palsy on the left side. He also had neurotrophic keratitis.
Doctor, 1 minute more.
Yes. So in spite of the corneal opacity, he had diplopia. And here I just want to highlight that we did a Nishida's procedure to his left lateral rectus along with medial rectus recession, and we got some amount of overcorrection, so that is also possible, but his diplopia was reduced, and so we didn't need to do any further procedure. So take home point is each case should be assessed on its own merit. We need in the resect procedure, we resect the paralyzed muscle if only there's some tone on FGT. Otherwise, we are compromising on the blood supply of anterior segment and unnecessary doing the procedure. The newer procedures like Nishida's give excellent result. And thanks from our team at Nagpur.
Thank you, Dr. Shubhangi. Wonderful talk. Like maybe it's a layman's question.
Yes.
Primary surgery has been done elsewhere, and then you go ahead to correct this non-recovering sixth nerve palsy. And if you're handling more muscles, don't you think there is that anxiety about anterior segment ischemia? And the second question is, could you do plication of the lateral rectus, or would that cause anterior segment ischemia too? Anybody in the expert panel?
Yeah, so planning the surgery, it's always better if we have the record what has been done previously. And if there is no record, then maybe we need exploration. We need to do exploration. And plication, again, as I've said, resection or plication of the lateral rectus, we can think of doing only if there's some tone on the FGT. So otherwise, a totally paralyzed muscle, there's no point in plicating or resecting it. But if there is some tone on the FGT, plication would be a better option than resection, because we are again not disturbing the anterior segment circulation.
Murli, would you want to add anything on this?
Yeah, I have a question for Dr. Shubhangi and the panel in general. Now we are spoiled for choice with a plethora of transposition procedures that are available. The half tendon, the full tendon, on either superior rectus or inferior rectus transposition, and of course the belly transfer or the Nishida and its multiple tweaks. So how do we really go about selecting which procedure to do?
Again, it depends on age of the patient. The patient, like both those ladies were elderly, they had hypertension. So we need to see which cases are more prone for anterior segment ischemia. Maybe in a younger patient, we could do both the things combined and take a chance, but that one thing. And then depending on how much is the deviation, how much is the limitation of movement of lateral rectus. So that would decide whether we can get away with one muscle transposition or we need a two muscle split tendon or full tendon, because full tendon would be more powerful than split tendon.
Dr. Veena and Dr. Meenakshi, anything to add on this?
No, I agree with her. Nowadays, we go more for Nishida rather than for tendon this thing, because it's much more easier and reversible also if you, and there is no question of anterior segment ischemia. That's not.
Nishida also basically, I mean, if you take a larger bite and go maybe towards the muscle, not midway between the two muscles, go towards the muscle where you want to, where you want the action, probably the effect would be much more as compared to just what is traditionally been described.
Yes.
Anything, Dr. Virender, to add?
We go on to our next speaker, Dr. Nirupama Kasturi. She's there? Yes.
Yes, ma'am. Sorry, I was just saying that Madam has already covered there, but the only question I would like to say, ask here is that what is the transposition effect in relation to the Nishida versus like a SRT or a monorectus transposition? How do you compare that?
Yeah.
How much correction you get?
Full tendon transplant, if you do both superior and inferior rectus, I believe they are more powerful. But
Yes.
Even with Nishidas, we get a good 25-30 prism diopter of correction. If we combine it with recession of ipsilateral antagonist, then the correction goes up to 50-55 prism diopter. So it's quite a powerful. In fact, that patient, that young boy of angiofibroma, I got some amount of overcorrection by just operating the left arm.
Thank you.
Thank you.
Time, we have to move on. We have with us Dr. Nirupama Kasturi, who is the additional professor and head of the Pediatric Ophthalmology Department, Strabismus and Neuro-Ophthalmology from JIPMER, Pondicherry. And she's going to talk on managing large angle strabismus, third nerve palsy with nil medial rectus function. So, on to you.
Thank you, Dr. Chitra and Dr. Murli and team IEDU for this excellent pediatric ophthalmology update. So managing a large angle strabismus in cases with third nerve palsy and nil MR function is a daunting task for us as strabismologists because of the various challenges that we encounter. So the third nerve supplies 4 extraocular muscles and all these are paralyzed. And there is overaction and contracture of the spared superior oblique and lateral rectus muscle. And along with that, in cases where there is trauma or compression, we get aberrant regeneration and pupillary involvement with anisocoria, loss of accommodation, and there is ptosis. And correction of ptosis is also difficult because of the associated poor Bell's phenomenon. And in congenital third nerve palsies, there is always a dense amblyopia, which also has to be addressed in these patients. So the various points that we have to consider is, first of all, counsel the patient adequately and explain to them the realistic goals of the strabismus surgery. And we have to individualize the treatment based on the extent and the recovery of the nerve palsy. So our aim should be to eliminate diplopia in primary and down gaze, which are required for the day-to-day activities. And we have to aim for an adequate alignment of the eyes in primary gaze to give a good cosmetic outcome, especially in young patients. And we can also consider staged approach because this helps us to assess the results of one surgery before considering the next option, and that gives a better outcome to the patient. And stage procedures also will help to avoid anterior segment ischemia. The other points that we have to consider are what is the extent of the third nerve palsy, whether it is a complete palsy or a partial palsy, and what has been the extent of recovery. And we have to wait for at least 6 to 8 months before planning any surgical outcome to ensure there is adequate recovery of the nerve palsy. So as Dr. Shubhangi has mentioned, we should always do an FDT and FGT before planning the surgery because we need to know if any residual MR action is available to plan for a resection or plication of the MR, and also check for the tightness of the lateral rectus. And we should also explain the option of contralateral eye surgery, which many patients may not prefer. And this will be useful when the exotropia is very large and one eye surgery may not be sufficient, or in cases of aberrant regeneration, where it is a good option to operate the contralateral uninvolved eye. So if it is an incomplete nerve palsy or with partial recovery and there is a good MR action, then we can go for a recess resect procedure. As in this patient with left third nerve palsy, you can see that the adduction is beyond the midline, and ipsilateral recess resect procedure can give a good alignment in the primary gaze. If there is an associated aberrant regeneration, like this patient with left third nerve palsy, you can see on adduction, there is a eyelid retraction and improvement in the ptosis. So in such cases, we operate the contralateral eye, the right eye in this case, and the lateral rectus is recessed and medial rectus is resected. And the induced esotropia will cause a fixation durus, which will move the left eye, and it will correct the exotropia as well as the ptosis in the same sitting. But now, when we have cases of complete third nerve palsy, where there is absolutely no adduction, this becomes a surgical challenge. And there are various options which are available, which we will go through one by one. So when we do a forced duction test and there is no mechanical restriction, and also the fourth generation test shows some medial rectus function, then we can do a supramaximal recession of the lateral rectus. Usually we do only 9 mm lateral rectus recession, but in this condition, we can go up to 12 to 14 millimeter. And similarly, we can do a large medial rectus resection of more than 8 millimeter, and we can correct the exotropia in some patients. If there is no medial rectus function, we can also do a vertical rectus transposition to the medial rectus with ciliary sparing to avoid anterior segment ischemia. And this can be done only if the vertical muscles have recovered. But in third nerve palsy, sometimes the superior rectus and inferior rectus are also paralyzed. And in such cases, we cannot do the vertical rectus transposition. So the next option would be the lateral rectus fixation to the periosteum of the lateral orbital wall. So this actually gives a better result over the large lateral rectus recession, and it removes all the action of the lateral rectus, and it can also be combined with a medial rectus resection or a plication. This is done using non-absorbable sutures like 5-0 Dacron or Ethibond. And it is important to ensure that the tenons layer is covered back to prevent the lateral rectus reattaching to the globe. And Velez et al. Have shown that this technique is a reversible and profound weakening procedure for the lateral rectus. The next procedure that can be considered is globe fixation to the medial wall periosteum. And this surgery has shown a stable alignment, especially for cases with large exotropias and nil MR function. But the disadvantage is there is absence of extraocular movements. So the patient will not have any adduction or abduction following this technique. And
We've lost
done
her.
using several techniques, like Dr. Saxena et al. Have actually populated the pre-caruncular approach for this procedure and have shown a good outcome. The next technique is the medial rectus transposition to the lateral rectus. Because the medial rectus is paralyzed, we have to use the action of the lateral rectus. And the entire lateral rectus was transposed by Taylor et al., who first described this technique. But Kaufman actually popularized the splitting of the lateral rectus into two halves. And he had actually transposed it to a retroequatorial position near the vortex veins. But this technique can cause some damage to the vortex veins, resulting in some hemorrhage or even choroidal effusion. So Gokigit et al. Have actually modified it and transposed it close to the borders of the medial rectus insertion, and they have shown good results. Dr. Sukija, who is there with us, they have actually published a series of transposition and have actually shown that transposition alone could correct the exotropia from 80 to 90 prism diopters to around 30 to 10 residual exotropia. And when it is combined with the medial rectus resection in the same situation or in the subsequent setting, it can actually correct even the residual exotropia and provide good alignment to the patient. The other technique, which was again reported by Dr. Saxena et al., is augmenting this split lateral rectus transposition using this posterior fixation sutures. And this has actually improved the outcome of this technique. And for cases with exotropia and significant vertical deviation like hypertropia or hypotropia, we can use a full tendon lateral rectus transposition. If there is a hypertropia, it can be transposed.
Doctor, 1 minute more.
Yes. And if there is a hypotropia, it can be transposed superiorly, and that gives a good outcome. And Dr. Saxena et al. Have also reported the cross-action transposition, which can be used with adjustable sutures. And this can actually help us to even adjust the alignment post-operatively. And it gives a good outcome. So this technique has become popular now for cases with nil MR action. The other last is the superior oblique transposition, which was difficulty and associated hyperdeviations and paradoxical movements. It is no longer practically used in many cases. So to summarize, whenever there's an oculomotor nerve palsy, if it's a partial palsy, we can go for the conventional recess resect. And if there is aberrant regeneration, we can do the contralateral eye surgery. If it's a complete palsy, then the three best techniques that can be adopted are the lateral rectus fixation to the periosteum, or the globe fixation to the medial wall periosteum, or the split lateral rectus transposition medially. So this is one of my patient who I operated for congenital third nerve palsy with a large left lateral rectus periosteal fixation and medial rectus resection. In the immediate post-op, she had a good alignment, and subsequently we did a ptosis correction. But after 1 year follow-up, again she's having a small exo deviation. And another interesting case where a newborn child presented to us with a orbital tumor, which was a PNET. It was treated for the tumor, but post-operatively, the child had a large exo deviation with nil MR action. And we did a large lateral rectus recession with medial globe fixation to the orbital periosteum. And the child is able to maintain binocularity with a small face turn, and also with amblyopia therapy and patching, the vision also was improved to around 6 by the right eye. So although the surgical results can be giving a good outcome, sometime in complete nerve palsy, the patient may start with no diplopia, and a surgical correction may give rise to disabling diplopia to the patient. So this also has to be explained, and if there is post-op diplopia, we may still have to use prisms to correct the diplopia and primary gaze, or even plan for secondary surgeries. Thank you very much for your patient listening.
Thank you, Dr. Nirupama. You covered it so well. Murli, you think you have any question, or do we go on to the next speaker? Wonderful talk.
Thank you.
What I wanted to ask was like how tight would the LR be to decide between LR to MR transposition vis-a-vis LR deactivation with a medial rectus plication. So usually you say that if the LR is very tight, you don't really do the LR to MR transposition. So Dr. Jaspreet or Dr. Veena, you would like to take that question?
Yeah, there might be some interruption because I'm traveling. Can you hear me?
Yes.
Yeah.
So again, some people would even recess the lateral rectus. So the problem is that even a recessed lateral rectus sometimes shortens. And in those cases, it becomes tight. So it really becomes difficult. But the FTT has to be free, just free. Otherwise, what will happen is you will not be able to take the lateral rectus up to the medial rectus. So depending upon the tightness, you might have to leave it just midway. Just take it across the vertical recti and not up to the medial rectus. So that will give you, you can say, an inconsistent result. So probably the lateral rectus has to be totally free for it to be transposed up till the medial rectus.
Yes. Thank you. Thank you, Dr. Jaspreet. We go on to our last speaker, Dr. Prachi Agastya, who's again a pediatric ophthalmologist and also an adult skin surgeon and a neuro-ophthalmologist from Magarshi Hospital, Mumbai. She is going to be talking on managing large angle strabismus with concomitant exotropia. On to you.
So very good evening. I'm the last speaker for the day. Am I audible and is my screen visible?
Yeah. Yes.
Slideshow has happened. No, it's not happening.
Slideshow hasn't happened. You'll do it now.
Yeah. Okay.
Yes. Okay.
So thank you, Chitra Madam. Thank you, Murli sir, for the opportunity. I will just begin with my topic. So the subheadings that I'm going to speak under is as shown in the slide. So to begin with, what is large angle exotropia? So we have variable definitions as to exotropia measuring more than 35 prisms to anything more than 50. But for practical purposes, anything more than 50 is considered to be significant. What is the real cause of the exotropia? So the common thing that was thought of was excessive divergence. But is that really true? Belchowski proposed the disorder to be a position of rest modified by convergence, and this was actually confirmed by Yampolsky in his EMG studies when they saw that the lateral rectus does not really fire when the eye moves into exotropia. The clinical presentation involves a childhood onset exotropia in the form of infantile XT, a decompensated intermittent exotropia, or sometimes a sensory exotropia. we need to remember that a childhood onset exotropia could be a soft marker of neurological or developmental delay, and deficient or absent convergence is many a times present in these patients. Amblyopia may or may not be present. Coming on to the clinical assessment, so some features specific to large angle exotropia is sometimes you may have an X pattern exotropia due to pseudo overaction of the obliques, as is shown by the red circle pseudo overaction of the inferior oblique as well as the green circle pseudo overaction of the superior oblique. So this is mainly because of the tight lateral recti in patients having long standing exotropia. And the globe basically slips over the because of these tight recti, wherein we get these patterns. However, the fundus examination needs to be done to assess torsion and to rule out true torsion to see if oblique overaction is accompanying the large angle tropias. And measuring in side and vertical gazes is also important to rule out any true patterns as well as any small vertical deviations that may accompany the horizontal deviations. A patch test is very important because large deviations in intermittent exotropia can also be kept latent to the tune of even 60-65 prisms. And it is important to uncover the entire deviation to get a good successful surgical result. When we assess these patients, we obviously need to measure their angles using a prism cover test. So horizontal base in prisms are used, which are split over each eye. As we know that the horizontal prisms cannot be stacked over each other. However, if there is an accompanying vertical prism, a vertical and a horizontal prism can be stacked. Alternatively, we have the use of this prism holder innovated by Dr. Jitendra Jethani, wherein a single person can evaluate the large angle exotropia without the help of an assistant to hold the second prism. Other important points to be considered is when we split the prism, the deviation that we get is not an exact sum of the separate prisms, and there are charts to this effect which we should make use of to know the actual deviation. Otherwise, we may land up with an undercorrection. Also take into consideration the refractive error whether the child or the patient has high hyperopia or myopia. And we need to use charts to correct the same because we know that minus measures more. So if you're measuring a myopic patient, the actual deviation you're measuring will be much more because the concave lenses of the myopic correction have a base out effect. Also, binocular single vision needs to be assessed to rule out anomalous retinal correspondence. Please, we should hold prisms in free space or put in Fresnel prisms to assess if the patient is having fusion or at least not having diplopia, and to know their range of fusion. They are one of the worst patients to have overcorrection with uncrossed diplopia because they do not tolerate this at all well in the post-operative period. Coming to the management, so surgical treatment is a cornerstone of treatment. There are a host of procedures that have been described. Let me just go through them about the pros and cons. So bilateral lateral rectus recession. So that has been one of our favorite procedures to treat exotropia. So recessions from 7 to 11 millimeter can be done. However, good results are reported from 35 prisms to max 50 prisms. But there are 100% poor results reported with only this procedure when the deviation is more than 50 prisms. So why do bilateral lateral rectus recession fail? So basically the muscle continues to exert its action when the direction of action is perpendicular to the arc of contact as is shown in this figure. When we do larger recessions further and further apart, this arc of contact is lost and that recession may not be so effective. Also, there are these lateral rectus pulleys which are there at around 16 to 31 millimeter from the lateral rectus, and they exert an opposite force on the lateral rectus beyond this point, making the larger recessions ineffective. There may be measurement errors when we operate because a straight caliper is used on a curved surface which can be overcome by using a Scotch tool. Also, there will be creeping up of the muscle, especially if hand-back techniques have been used for larger recessions. Going on to the second procedure is a bimedial resection. So good results are reported with bimedial resections to the tune of 8 to 12 millimeters for deviations even more than 60 prisms. However, these are short-term studies with 6 months post-operative follow-up, and there could be some limitation of abduction even in the long-term period, which we need to take into consideration. Good results have been reported even in infantile exotropias. in the short-term area. So we should consider this sometimes as a primary procedure as compared to bilateral lateral rectus recession. Large unilateral recess reset, it is one of the favored procedures as Dr. Lakshmi also presented. The pros are it's a monoocular procedure preferred in sensory exotropia. It avoids exposure of the dominant eye to the risk of surgery, may give more stable results. However, the risks include abduction limitation, palpebral fissure narrowing, and enophthalmos. But sometimes these cons can be put to good use. So this is an example of a patient who had sensory exotropia due to optic atrophy following a road traffic accident. So he underwent 11 millimeter LR recession with resection. So if you can see, his globe looked a little larger as compared to the other eye. The slight enophthalmos that we got after the surgery has helped in improving the facial symmetry. Then the next is the 3 or the 4 muscle horizontal muscle procedure. The reported success rates are between 40 to 85. There is a risk of induced lateral incompetence. However, the recent studies by Welles group have reported good success rates with recurrence rate of 20 to 22%, and hardly anybody had any induced lateral incompetence. Lesser surgery can give more correction in these patients. This has been my procedure of choice for treating large angle exotropias. This is a case example who's a girl operated at 4 to 5 years of age, who has maintained her binocularity and alignment even 2 years post-operatively. As said, there is hardly any limitation of duction in the long-term post-operative period as the muscle just takes up the slack. Good results have been reported by Chen et al. Even in the 1 year post-operative period, but an important finding is that 75% experienced an exodrift within the first 2 months. So an important tip that I wanted to share is we need to look for convergence insufficiency in these patients in the early post-operative period. If that is there, that needs to be taken care of with either prism glasses or convergence exercises. If that remains unattended, they're definitely bound to have a recurrence in the early post-operative period. Then is a 4 muscle procedure by Edward Rath, which involves operating even on the obliques. So you remove any...
1 minute more.
Yes, sir. Removes any abducting force of the obliques on the globe, and there is lesser risk of anterior segment ischemia. Muscle transplantation procedure is another thing, addition to the armamentarium, which involves transplanting the part of the resected medial rectus to the lateral rectus, which allows us to perform larger recessions with reduced chances of palpebral fissure changes and hardly any limitation of abduction, even if we do larger recessions. The other 2 procedures is what Dr. Kasturi has just stated, the lateral rectus periosteal fixation as well as the nasal transposition of the split lateral rectus. So basically these 2 procedures are used for extreme exotropias, and I would probably not, these are not preferred procedures for comitant exotropias as we get alignment only in the primary position. The horizontal excursions remain limited and the globe is frozen. So to sum up, the 2 muscle surgeries seem to have inadequacies for treatment of large angle exotropia. 3 or 4 muscle horizontal surgery seems to be a right choice for management. The 4 muscle procedure involving the obliques or muscle transplant are viable options in unilateral large angle sensory exotropias. Thank you.
Thank you, Dr. Prachi. That was again another wonderful talk. Murli, some very small question to be asked. Yes, don't you think with all so much of muscle, I mean, if you cross the limit of how much you would normally do in these very large angle exotropia, don't you think there could be palpable fissure changes which can happen, or it's not?
Yes, ma'am. So that's what I highlighted basically. The unilateral recess reset, that is what is there if you do very large angles. So that is an advantage of doing a 3 muscle or a 4 muscle surgery and splitting the procedure on both the eyes. If we are bound to perform that procedure on a unilateral eye, say in case of sensory exotropias, then we would probably, take help of the transplant procedures or augment it by using, even weakening the obliques and try and reduce it basically. So that's how we tend to tackle that.
Murli, any question before we conclude?
No, madam.
Dinner time. I think it goes without saying that all of you have really enjoyed yourselves in this webinar. Imagine me and anterior segment surgeon. I enjoyed it so much, as if like I read one of the best storybooks of my lifetime. So thanks a lot for such a wonderful webinar. Each of you excelling the other, but yet you couldn't excel because all of you were on par. Such a good webinar. Thanks so much for being there right till the end. And Murli, do add something for your dear friends.
Yeah, thanks a lot. Thanks, Dr. Arif, and thanks, Lakshmi, for that excellent sum up.
I think you should share this video link with a lot of your friends to watch. It's because it's truly a very nice webinar and very different topics have been dealt so amazingly well by all of you. Thanks so much.
Thank you.
Good night.
Thank you. Thank you, madam. Thank you, sir.
Thank you. Thank you for the wonderful webinar.
Thank you.
Thank you.
Bye-bye.